helped train Dr. Andy Bombeck, who has done spectacularly well in so many ways in addition. It is my hope that I can go with you through what may cause ANCA vasculitis. And our work really stems from patient-derived questions. If you see patients with any autoimmune disease and ANCA vasculitis being one of them, the questions that you're going to ask is, what caused my disease? How did I get it? What factors will make my disease go away? What will make it go away? And since these are all relapsing and remitting diseases, the question most always comes, once you're in remission, then what will prevent my disease from coming back? What will prevent a relapse? And so during the course of this next few minutes, I'm going to try to describe what we know about about the pathogenesis of ANCA vasculitis, and then some of what may cause the disease in and by itself, although the answers to so many of these questions remain unknown. What we know, for starters, is that this is a group of diseases that are defined by a relative lack of immune complex deposits, either those that are found in a linear fashion, anti-GBM disease, or as immune complexes. And so from the very start of our thinking about the pathogenesis of this disorder, we have to ask the question, how does one get vascular damage when there are no immune complexes there? Coupled with the very well-known association, the name of the disease, there are two serological markers, which are more than serological markers: antibodies to proteinase 3, PR3 ANCA, and antibodies to myeloperoxidase, ANCA. And I'm going to show you in short order that these antibodies actually are very much participant in the disease process themselves, a disease process that affects vessels of various size, from postcapillary vessels all the way up to middle-sized arteries. Whenever one thinking about pathogenesis or immunopathogenesis, you have to ask the question of what is associated with innate immunity. That's what happens very quickly with neutrophils and monocytes and natural killer cells. And how do that part of the immune system cause disease? And how do we want to treat that? Folks will talk about that more later. And then what is the driving force that causes lymphocytes and plasma cells then to secrete antibodies, or autoantibodies in this case? So if one thinks about ANCA vasculitis, one has to think about what may produce the ANCA, loss of B and T cell tolerance, that then creates an antibody that results in injury as a consequence of activation of neutrophils and monocytes. And that whole process is influenced tremendously by genetics and by environmental factors that then go on to either resolve the disease, because it's either therapy or the immune system downregulates this process. You hope that you can downregulate that immune process, especially innate immunity, so that you prevent scarring, glomerular sclerosis, tubular interstitial fibrosis. So in this cartoon, what I would suggest is that we know a lot about what allows either myeloperoxidase ANCA or proteinase 3 ANCA to cause a neutrophil or monocyte to do what it does best, to cause reactive oxygen species production and the release of lots of toxic granule proteins. So if you think of a neutrophil, with most of the time, all of you have your MPO and proteinase 3 stuck within a primary granule. Those granules, that protein has to come to the surface of the cell, which can either occur as a consequence of a cytokine, and also probably as a consequence of dysregulation of the gene for myeloperoxidase and proteinase 3, and we'll get into that in a moment. Once you have antigen on the surface of cell, then antibodies can come and attack the cell, resulting in neutrophil and monocyte activation that causes endothelial cell damage. And literally every part of the right side of this cartoon has been nicely demonstrated in vitro from labs across the globe. What you also see on the this part of the cartoon is that we know that complement, especially the alternative pathway of complement, is very important in this process, as well as part of innate immunity. So we know that ANCA interact with its cognate antigen, whether cytokines are involved or not, results in the interaction of antibody, both through its Fc receptor and through direct engagement by FAB prime 2s, activating neutrophils and monocytes to cause diapedesis through endothelial monolayers to result in the vessel disease that was the hallmark of ANCA vasculitis. These in vitro studies are very much bolstered by wonderful animal studies from multiple parts of the globe. Here is one example. In our own laboratories, we have immunized myeloperoxidase knockout mice and then transferred. Once you immunize those mice, you can transfer to other mice antibodies to myeloperoxidase. You can transfer splenocytes, and you get a beautiful reproducible model of necrotizing and crescentic glomerulonephritis that looks remarkably like that which is seen in the human condition. And we know a lot about this now. We know that the antibody itself can cause the disease. Neutrophils are required. Priming makes the disease process work. T cells don't cause the acute disease. They're important in immunopathogenesis, of course. And interestingly, if you abrogate the alternative pathway of complement, C3 tickover, and then specifically interfere with the C5a receptor, you abrogate disease. And in fact, what you all know now as avacopan came out of studies from our labs in which the human C5a receptor was placed into mice, and then the peptide, which now is known as avacopan, really abrogated disease activity. There is for certain in animals a genetic component of all this. There's some mice strains that have way more glomerular crescent disease and some that you hardly can get necrosis or crescents at all. And this animal counterpart has a human part as well, which I'll show you. So here are the studies. An orally active antagonist of human C5a receptors when given to mice really did decrease glomerular crescent formation and, quite frankly, hematuria quite quickly. So what caused my disease if we transition from mice to humans? Well, the answer is yes, there are environmental components. Those are certainly, you know that from the drug-induced vasculitis literature, propylthiouracil, levamisole. Now it's very much hydralazine that's causing things. There's a seasonal association which speaks to a number of pathogens, mostly viral, that are associated with this disease process. And then multiple studies have shown that silica and the intensity and duration of silica exposure are some environmental pressures, and I'm sure there are many, many more. Genetics plays a role, and there have been two large studies, GWAS studies, one from Europe and one from the United States, and they say the same thing. They say that MHC-HLA is really important. It's almost more important defining PR3 ANCA versus MPO ANCA than the words GPA or microscopic polyangiitis. And those HLA genes, proteinase 3 and its inhibitor, all came out in that GWAS. And the North American GWAS shows almost exactly the same, including a interesting gene that's been associated with familial autoimmunity, PTPN22. So there are environmental processes and there are genetic forces at play in the human disease. But we know a lot now about the antigens themselves, a whole lot. Myeloperoxidase and proteinase 3 are overwhelmingly the two proteins to which the ANCA antibodies react. And one of the questions has to be, what do we know about these autoantigens? And is their perturbation part of the pathogenesis or the immunopathogenesis stories? On the left side, you see here a ribbon diagram of the a heterodimer, which we know is myeloperoxidase, and on the right side, a ribbon diagram of proteinase 3. And the first thing you have to ask is, are antibodies attacking these molecules all over the place? Or is, in fact, the targeting highly specific? And I'm going to show you in a moment that it's highly specific. So what then controls a normal self protein? You all have myeloperoxidase, you all have proteinase 3. Why do some people get an antibody to it? And one possibility is what Billy Hudson has described for anti-GBM disease, in which there's an unfolding there of type 4 collagen. Here, there may be a number of factors, one of which turns out to be epigenetic control of both myeloperoxidase and proteinase 3. And in patients, and not in normals, there is increased expression of both myeloperoxidase and proteinase 3 during active disease. And intriguingly, even though they are on different chromosomes, they seem to go up together. We know that when you have increased expression of myeloperoxidase and proteinase 3, you make brand new antibody. We know when, you make brand new antigen. You make more antigen. We know when you have increased expression of myeloperoxidase and proteinase 3 that you increase protein expression and you increase the ability of a neutrophil to be activated by Anca. We know that this process is silenced by histone methylation, and we also know that there is a secondary silencing phenomenon of DNA methylation of a very specific CpG island within the proteinase 3. And in those patients in whom that particular open CpG has been methylated, there is far less chance of having a relapse. And in fact, if that island is methylated, this is in months, a much higher chance of having a longer term remission. So there's something about the expression of the antigen all by itself. So the next question is the antibody, myeloperoxidase or proteinase 3, attacking everywhere, a polyclonal antibody response, or is it in fact pretty restricted? And I would argue that it is pretty restricted. And in a series of studies of examining how you take myeloperoxidase, you add it to Anca, the antibody, and you cleave off everything, all the protein around where the antibody protects a little piece of the epitope, and then ask the question, what epitope is that antibody binding to? What you discover, in fact, is there are epitopes that are found in patients with active disease that persist during remission, that are also common in patients who have asymptomatic or normal individuals. And those patients who are in remission, those active antibodies to very specific proteins, parts of the myeloperoxidase molecule, go away. It turns out that there's one part of this molecule of myeloperoxidase. It seems to be very much more prevalent in active disease than in remission. And that part of the myeloperoxidase molecule is the same part of the myeloperoxidase molecule that our Australian colleagues have really used very nicely to show that you can immunize with mouse myeloperoxidase and cause disease. And when you look at the human epitope and the mouse epitope on myeloperoxidase, you find, in fact, that the T cell epitope has this RKIV group of amino acids, which look very similar to the human B cell epitope. Mouse and man, in this case, converge. We have also then looked at what T cells are reacting to. And you can do this by examining what's known as the immunological synapse. What does the antigen presenting cell have? What's the antigen in that antigen presenting cell that then interacts with the effector T cell? And data from now literally across the globe would suggest that both mouse and human react to this blue and partly yellow portion of the ribbon structure of that part of myeloperoxidase. The human antibody binds to the yellow and purple part of that molecule, and the mouse CD8 region reacts to the bottom part. And if you, in fact, get rid of that helical structure, the antibody reactivity goes away. Think about it, though. We know so much now about how the importance of this portion of the antibody, of the antigen. Wouldn't it be nice to target B cells, autoreactive B cells, based on this reactivity? So the next part of this interaction is not just the antigen, it's of course T cells. And they're T helper cells, they're effector cells, and T regulatory cells. And we now know quite clearly that CD4 positive T cells in ANCA vasculitis are not suppressed. You have increased Th7 T cells in the periphery, and they're very much specific for the autoantigen. Look, I can show you in a flow plot. Most of you don't look at flow plots, but here on the left is a healthy control of effector T cells, CD4 positive T cells. Look at the red splot on the left. In patients with ANCA disease, that whole group of green and red dots shifts to a whole nother group of CD4 positive intermediate cells, we call them, that proliferate and are not controlled by T regulatory cells. And these cells turns out to be antigen exposed, chronically antigen exposed. So we've been exploring that whole interaction using this concept of the immunological synapse. What exact part of the molecule of proteinase 3 or myeloperoxidase are these cells and patients seeing? And I've got to digress for a moment here because I need to define how we're defining active disease, clinical remission, or long-term remission so that you can understand the next set of experiments. So active disease, you know, it's a Birmingham vasculitis activity score of over 0. You know that they have a disease, hematuria, glomerular disease, pulmonary processes, and you'll hear more about the clinical picture later. In our hands, clinical remission is a BVAS score of 0, no evidence of disease. And we chart review 3 months before that clinic visit and 3 months afterwards. So this is a 6-month period of time of clinical disease remission. And then we have now, out of 1,000 or so prospectively followed patients, 1,300 actually, about 330 that we've gotten into long-term remission off therapy. Long-term remission off therapy, L-trots, no prednisone, nothing, sometimes for years, but in this definition for at least 12 months. And we've been asking ourselves the question, then, what is the reactivity of T cells, effector cells, and regulatory cells in these 3 different states? And intriguingly, what we have been able to examine is that there really there is a very clear difference of how a patient with active disease, a patient in clinical remission, when compared to a patient in long-term remission off therapy, it has the interaction of the molecule, in this case, a portion of proteinase 3, to that HLA portion of that immunological synapse. So here are a group of T cells, antigen-presenting cells that are binding peptide. And of course, in healthy controls, there's some binding of proteinase 3 or, quite frankly, myeloperoxidase to HLA DPP1 cells. Patients who are in clinical remission on therapy, boy, they still interact with that peptide a lot. And active disease looks just like this. But patients who are in long-term remission, by George, they no longer react to the peptide. Their antigen-presenting cells no longer are responding to peptide. So this interaction of T cells, T effector cells, and we'll show you in a moment regulatory cells, is part of the way that you get disease, but also the mechanism by which you no longer react to self. And of course, the question is, how does that happen? But this immunological interaction of HLA and proteinase 3 associated with this person running away in long-term remission off therapy is incredibly important, not just from what it teaches us about biology, but also gives us an opportunity to think, can we use this interaction of antigen presenting cells gotten from peripheral blood and the cognate protein, proteinase 3 or myeloperoxidase, and if they no longer interact, does that do more than define clinical remission? Does that now define at least autoantigen non-responsiveness and maybe immunological remission? So another part of this interaction is, of course, T regulatory cells, because I've shown you how these T effector cells are proliferating and reacting to antigen. How come the T regulatory response, which is supposed to turn this off, isn't working? Well, in this autoimmune disease and in so many others, there's increased T regulatory frequency. You have more of them, but they don't work. And the question is, why don't they work? Well, it turns out that T regulatory cells are remarkably heterogeneous. We've done single cell sequencing, and what I can show you is it's not only that these people in long-term remission, here's healthy control, here's long-term remission off therapy, here's a patient in clinical remission, and here are patients with active disease. These patients in long-term remission have in their T regulatory cells more of specific proteins, and more specific proteins that may have much to do with their ability to turn off the T effector cells. And figuring out that pathway may also tell us a lot about what's causing the disease, but also then how to turn it off. So there's one other player here. The autoantigen we've talked about, T effector cells we've talked about, T regulatory cells we've talked about, and then of course there are B regulatory cells, and they're critically important too. In addition to B cells that produce antibody, you have B regulatory cells that are there to suppress the immune response. And yes, they work closely with T effector cells for sure. And they're very much associated again with HLA. B regulatory cells work when they're producing IL-10. And what you'd like to do, of course, is to have B regulatory cells that produce IL-10 and decrease the immune response. Please remember that when you use repetitive rituximab, you eliminate all B cells, including the protective B regulatory cells. Wouldn't it be nice then to just target autoreactive B cells that are producing autoantibody, leaving the B regulatory cells alone? So how do we take everything that we've just described, that we've learned about this disease process? Wouldn't it be nice if we could silence the autoantigen transcription, make it so that myeloperoxidase and proteinase 3 gene expression was as silenced as your own myeloperoxidase and proteinase 3 gene expression? Wouldn't that be nice? Could we directly suppress it? Can we disrupt this epigenetic dysregulation? Or can we inhibit pathways responsible for neutrophil activation? Can we target the immunomodulatory arm of the immune response? And one of the possibilities is to expand functional Tregs from the patient, take their T cells, isolate their functional T regulatory cells, or stimulate T regulatory cells that are functional, expand them and give them back to patients. And we're well on our way to doing exactly that. You can imagine a person who was in remission, clinical remission, and now you want to get them in long-term remission off therapy. Can you give them back those very different T regulatory cells that promote long-term remission off therapy? And before that, can you actually then target antigen-specific autoreactive B cells, the nasty B cells, with bispecific antibodies, using all that we know in myeloperoxidase, for example, the critical parts of the myeloperoxidase protein that are driving the pathogenic autoreactive B cells. Because what, of course, all of us would like is to use what we've learned about the pathogenesis of this disease, both the innate part of the immune response and the adaptive part of the immune response, to target our therapies to quell acute injury, and then, in fact, to understand the adaptive immune response, T cells, B cells, and result in disease resolution with minimal scarring, which is, of course, the normal response to uncontrolled innate immunity. I like this slide. It sort of summarizes what many of us have been working on for so many years. Here is a dragon with its eye and flames coming out of its mouth, about to chomp on this poor unsuspecting capillary with a red cell contained within it. Let's use what we've learned about pathogenesis to specifically target this serpent and not the whole immune response. Thanks so much for listening.
Thank you very much. Dr. Falk, you're able to hear me?
I can hear you beautifully.
Perfect. We got a bunch of questions. I think we're only going to have time for one. And it's a question we get a lot. How do you make sense of these patients who are called atypical ANCA, but their MPO and PR3 tests are negative?
So first of all, I'd ask the question, if their ANCA if they have a perinuclear ANCA, and that's where this happens most frequently, if their ANA is positive, then in fact there is no consequence to that finding. It's really just an ANA, an anti-nuclear antibody. If their pANCA or cANCA is positive and there's no other autoantibody, no ANA, no ENA, then in fact those patients, you have to look for a vasculitic phenomenon. And most commonly, I have to tell you, patients who have that process have mostly upper respiratory tract disease. And in fact, some of those patients actually have antibodies to myeloperoxidase that have been blocked in the clinical assays because of the normal inhibitor of myeloperoxidase known as ceruloplasmin.
Excellent. Thank you very much, Dr. Falk. For everybody else who submitted questions, we'll try to have the course directors try to address them online. We're going to move now to...
And I think the kidney biopsy is important from a number of perspectives. And we'll, first of all, just look at the patterns of injury and then talk about how to integrate the status of the pathology in the kidney biopsy specimen with potential patient response to therapy and outcomes. So, of course, as this audience knows well, ANCA, small vessel vasculitis, affects many tissues, but the main targets are the small vessels, the venules in the skin, for example, causing hemorrhagic microangiopathy that causes the purpura, involvement in the lungs with a hemorrhagic pneumonitis, capillaritis, that of course is potentially life-threatening, and arteries in virtually any tissue of the body, including the brain and the gut, skeletal muscle, peripheral nerves, causing multiple clinical manifestations. ANCA glomerular...
One second. Can we just interrupt one second? Can you share your slide?
Oh, sorry.
Perfect. Thank you.
Are you seeing them now?
Yes. Yes, we can see them now.
Okay, good. I don't seem to be able to get them to go up and down at this juncture there. Okay, there we go. Sorry for that. So not sure what my problem is here. There we go. Okay, so the vasculitis in patients with ANCA disease, of course, has multiple clinical pathologic syndromes. Glomerulonephritis is the most ubiquitous factor, though, across renal limited vasculitis, microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. Crescentic glomerulonephritis can be a prominent feature, least so in EGPA. But in all of these patients, it's the presence of the vasculitis with or without granulomatous inflammation and concurrent eosinophilia and asthma that defines these various clinical pathologic syndromes, as you're familiar with. In microscopic polyangiitis and GPA, necrotizing glomerulonephritis is very common. And so nephrologists are frequent clinicians involved in the care of patients with NPA and GPA. In EGPA, glomerulonephritis may be present, but in the approach that's used by many rheumatologists and pulmonologists, diagnosis of EGPA is in patients sometimes who do not have evidence for kidney involvement, and a high proportion of those patients are ANCA negative. However, when patients have glomerulonephritis in the context of features of EGPA, they very often are ANCA positive. So it's really a subset of EGPA. These clinical pathologic syndromes do correlate to varying degrees with the specificity of the ANCA. Those with myeloperoxidase specificity, especially in North America and Europe, but even more so Asia, with renal limited disease have specificity most often for myeloperoxidase. So nephropathologists and nephrologists often see MPO ANCA positivity. But in patients who have upper respiratory tract disease in particular, lung cavities from the granulomatosis and saddle nose from destructive granulomatous inflammation in the nasal region, PR3 ANCA is a more frequent finding in the patients. The glomerulonephritis in all of those settings has the same pattern of injury. In the acute phase, there's necrotizing injury that often results in spillage of plasma into the site of necrosis and formation of fibrin through the coagulation cascade and associated crescent formation. Here, an early active lesion with segmental fibrinoid necrosis and a crescent. The PAS stain demarcates the edge of the tuft nicely, and you can see the crescent. You can also see a zone here of destroyed basement membranes and mesangial matrix indicative of necrosis, and the silver stain has similar capabilities of distinguishing the necrosis and the crescents from the tuft itself. Higher magnification, again, we can see the fibrinoid necrosis that stains red with a trichrome stain, and it will stain blue or green once it develops fibrosis secondary to the initial necrosis, and the silver stain showing the end to a glomerular basement membrane. Normally, the basement membranes are endless, and so if you find a gap, there has been a break in the glomerular basement membrane. Within a week or two, in our animal model, in just a week, the fibrinoid necrosis is replaced by collagenous matrix as a scar, and the cellular crescents evolve through fibrocellular to fibrous crescents. So if on a biopsy from a patient, you have a significant proportion of glomeruli with segmental scarring, that doesn't necessarily mean the disease is months earlier. It can mean that those sites of injury occurred just a few weeks earlier. As we'll see, this scarring of glomeruli and the preservation of normal tufts is an important feature in what were called renal risk scores and are now being called kidney risk scores in ANCA disease. The kidney also has, in addition to glomerulonephritis, and rarely in the absence of identifiable glomerulonephritis, other vasculitis within the kidney parenchyma. Here you can see a venular component of the vasorecti, and it looks very much like what a venule in the dermis would look like, a segmental zone of fibrinoid necrosis, some karyorectic debris leading to the leukocytoclastic terminology that's often used, with the lesion really looking very much like what was in the glomerular capillaries. And here a small interlobular artery in the kidney with a zone of fibrinoid necrosis and leukocytoclasia and leukocyte infiltration. So in some patients, one does see vasculitis beyond the glomerulus. As I'll note later, when you see that vasculitis in a patient who has anti-GBM disease, you need to worry about concurrent ANCA disease. This medullary angiitis is not unique to ANCA disease, though. It can also be seen in kidney biopsies from patients with IgA vasculitis, including the HS purpura, like often in children syndrome, and in IgA dominant infection-associated glomerulonephritis that occurs in older patients, usually associated with staphylococcal infection, but other infections can occur. Of course, the immunofluorescence microscopy pattern that is most typical for ANCA disease in a kidney biopsy is this paucity of staining for immunoglobulin and complement, although we know, as Ron mentioned, that the antibodies and complement activation via the alternative pathway are critical to inducing this lesion, but they do it by interacting more directly with the leukocytes rather than forming substantial accumulations of immunoglobulin and complement that then attracts the neutrophils and activates them. So linear staining of anti-GBM disease, granular staining either of immune complex disease with immunoglobulins or C3 glomerulopathy. An important consideration I alluded to, and that is this concurrence of ANCA disease with anti-GBM disease. A substantial proportion of patients with anti-GBM disease have ANCA positivity, as high as a third of these patients in some series. And so anytime you have an anti-GBM patient, it's important to get ANCA testing as well, because that will impact in particular long-term outcome, as I'll come to. If you see non-glomerular vasculitic involvement in the biopsy in a patient who has serologic and immunohistologic features of anti-GBM disease, you're probably dealing with concurrent ANCA disease. So here's a nice series from Charles Pusey and his associates that compared renal survival and relapse in patients who had anti-GBM disease alone, which we know is the worst actor with respect to glomerulonephritis, ANCA disease, or double positive, ANCA positive and anti-GBM positive. The double positive patients have a more severe outcome, more in line with anti-GBM disease. An important distinction is that anti-GBM disease is one wave of autoimmune disease. Once it goes away, for example, by induction therapy, it rarely, if ever, has relapses. But the double positive patients have relapse rates similar to the ANCA disease patients, but these relapses are really in the ANCA disease component. So it makes sense. When you do have these overlapping circumstances, where you have immune complex disease like an IgA nephropathy that's ANCA positive and has 30% necrosis and crescents, they may very well have overlap with ANCA disease. I've already mentioned the anti-GBM disease. There are occasional, let's say infrequent, if not rare, circumstances where you have both an MPO ANCA and a PR3 ANCA. Importantly, when you have dual positivity, you may have ANCA and anti-GBM disease, or you can have increased deposition of immune complex type deposits and concurrent autoantibodies with infection-induced disease or drug-induced disease. So here's that study from Charles Busey's group, again, looking at these double positive patients. The younger patients who have anti-GBM disease infrequently have this double positivity. The double positivity in these darkest bars is more frequent in the older patients who more frequently have ANCA disease in general. So the ANCA disease has one peak here in older age. Anti-GBM disease has two peaks. These patients also have more pulmonary renal syndrome and these more renal limited. What we are seeing a lot of these days, and some of you may be as well, is drug-induced ANCA disease, and especially associated with hydralazine. This is a nice study from Columbia, and you can see that hydralazine-associated glomerulonephritis versus ANCA-GN without any implicated drug cause. There are some distinct features here. One of these is that this dual positivity, which is, as I noted, very infrequent in straight up ANCA disease, is much more frequent with hydralazine-induced disease and true of other drug-induced disease and infection-associated glomerulonephritis to an extent. And the presence of a concurrent ANCA, ANA, is typical for hydralazine-induced disease, which was once called drug-induced lupus because of this serologic phenomenon primarily, but also the biopsy can give you some hints because there will be a little less instance of absence of immunoglobulins and complement and a higher frequency of detectable deposits by immunofluorescence and by electron microscopy. So the pathology here can give you a hint that you should consider drug-induced disease, and the double seropositivity and presence of ANA is also helpful. So again, in these circumstances where there are these overlaps, be sure to consider drug-induced disease and infection-induced disease. Here's an example of hydralazine-induced disease, and you can see here by light microscopy, there's an element of endocapillary hypercellularity that we don't see typically in straight up ANCA disease. And there's crescent formation, of course, but there's not a very intense, but a clearly present immune complex accumulation within the glomerulus. And there's an in vitro phenomenon here in the kidney biopsy that gives a hint. There's an in vitro positive anti-nuclear antibody reaction that happens on the nuclei. This happens when the frozen section is cut and the plasma in the sample spills over the face of the tissue section, and the ANA antibodies grab a hold of the tubular nuclei in particular. But also by electron microscopy, here we can see a crescent. These are fibrin tactoids that represent the fibrinoid material we see by light microscopy. And beneath the glomerular basement membrane is a large subendothelial deposit, very much like what you'd see in a class 4 lupus nephritis. So in the last portion of the presentation, I'd like to talk about the dynamics of the lesions over time, and also the correlation of the proportion of lesions and whether they're acute or chronic with respect to the likelihood of a good renal outcome in the patient. As I mentioned, anti-GBM disease is a one-wave disease. So if you can stop it early on with appropriate induction therapy, there's just one little hump and then a certain level of scar. If you get a substantial proportion of acute injury before you can bring it under control, you're going to be left with a higher proportion of globally sclerotic glomeruli down the road. Anca disease is more like lupus nephritis with respect to the dynamics. It comes in waves, ongoing waves of acute injury. To begin with, it may be a small proportion of glomeruli that are affected. Some are necrotic. They evolve into sclerotic glomeruli, either globally or segmentally. But then there's another wave and scar, and another wave and scar. And until you can bring your patient into full remission, there's not going to be any more acute injury, but the scarring will persist. Now, with Anca disease, there could be a recurrence out here that would then push the acute lesions higher on the list. So the management of glomerulonephritis requires awareness of these recurring waves of disease. The lesions, again, that we saw earlier, histologically normal glomerulus. So how many of these are present in the kidney biopsy specimen is one of the better markers for outcome. Of course, if one says there's 25% necrosis and there's 25% of glomeruli with sclerosis, they typically don't say in the report, and therefore there are 50% normal glomeruli. It may be that in the future, we should be specifying in the report what proportion of histologically uninvolved glomeruli are there. Now you have to deduce it somewhat from most of the reports. There is, of course, the fibrinoid necrosis in active lesions, and then the scar. You can pair up this diagram at the bottom with the diagram at the top. Here's some glomeruli with uninvolved glomeruli as the pale pink color. The ones that are involved with fibrinoid necrosis in red here, and the scar as blue. And so early on, there may be a small proportion, less than 50%, of acute lesions and very few, if any, sclerotic lesions. These increase over time. Eventually, you start to accrue more scarring. And at some point, you may have, if you had a severe disease affecting most glomeruli, mainly sclerotic glomeruli. So there are these progressions that we've already talked about. The burden system was the first that I'm aware of that looked at this proportion of acutely injured versus chronically injured glomeruli and compared it with outcomes. There have been multiple evaluations of this system over time, and this has now also been accompanied by risk scores that include clinical and pathology parameters. But in the burden system, it's all the proportion of glomeruli. If 50% or more have no lesions, it's a focal process. If 50% or more have fibrocellular or cellular crescents, it's a crescentic variant. Mixed has greater than 50% injury, but not greater crescents versus necrosis. It's pretty much equal involvement. And the sclerotic greater or 50% of glomeruli with sclerosis. And you can see that this, in fact, did correlate with the kidney outcome over time. With the sclerotic group, more than 50% of glomeruli with global sclerosis was the worst performer, and those with focal lesions did best. And here, if you can knock out all of that acute injury with induction therapy early on, the kidney has a great chance of surviving. And this has been studied in other cohorts as well. This is another one that shows similar outcomes. Where there's been a discrepancy among the studies is that some show crescentic more severe and others show sclerotic more severe. And that's not surprising because the mixed group is very heterogeneous. You can have a mixed group with 40% crescents and 10% global sclerosis, or it can also be mixed, but it's got 40% global sclerosis and 5% crescents. So there's a big variation here in the mixed group. So if someone is classifying your kidneys by this classification and they say it's a mixed variant, it would be good to see if it's more active mixed or more chronic mixed. And here's a diagram showing this sort of phenomenon here, where you can have the active mixed during the earlier phase of disease, or you can have a mixed pattern later in disease. And the focal group also is an interesting issue. If you have a focal, that means less than 50% of glomeruli have a lesion attributable to the Anca disease. If it's mainly active focal disease, I think it would be worth considering induction therapy and have the opinion that you're going to have a good response to that therapy. On the other hand, if it's totally chronic disease, if you've got 25% of glomeruli with segmental or global sclerosis, I don't think that would be a context where you would be as aggressive about treatment if this was the only disease in the patient. But there are no data that I'm aware of that have looked at those two settings. So the final issue is the risk score. And the risk score combines a pathology parameter with a clinical parameter. And the parameter that's been identified as the most helpful, and again, the one you often have to deduce from the pathology report, is the percent of uninvolved glomeruli with respect to histology. So they're not sclerotic, they don't have necrosis and crescents. And also the interstitial fibrosis and tubular atrophy, which has been shown in virtually every form of glomerular disease to be a marker of outcome. And in this particular iteration of the risk score, the GFR. But depending on these parameters, a certain number of points is allotted. And then based on the total points in a given patient, you can predict outcome by the risk score. In this particular series of patients, there was a very poor outcome for the high-risk group. There's been a subsequent study on a large number of patients that has also shown that the normal glomeruli and severe glomerular scarring are good predictors of good and bad outcome, respectively. So those features are always one to evaluate. The improved, so-called, Anca kidney risk score. This has adopted the approach of many nephrology groups, including the ASN and the ISN and KDIGO, to do away with renal and use the term kidney, which is better known to lay populations. And so it's now called the Anca kidney risk score. A large series of patients here looking at outcomes. And the risk calculation has changed a little bit. Now creatinine is being used rather than GFR, but the normal glomeruli and the interstitial fibrosis are still the main factors that were identified as predictors based on severity. And a group was added of very high risk, which is basically a maximum score for these risk factors. And here you can see the data from the kidney risk score and the high risk group, which is only a small proportion of your patients that have that much injury at the time of biopsy, of course, does most severely. So integration of pathology features with clinical parameters is the best way to go, not the pathology alone or the clinical parameters alone. And this group recommends using their system, not surprisingly. So that's a quick view of the evaluation of the kidney biopsy and what lesions are important in predicting outcomes of your patients and making decisions about treatment of your patients. One issue that's not well defined in Anca disease pathology is whether or not repeat biopsies are valuable. Certainly in lupus nephritis, there's a realization that repeat biopsies are valuable in assessing whether there's an exacerbation of disease or just chronic progression at a time. We see a reasonable number of repeat biopsies, and I think they may become more frequent. I think it could be a better marker for patient care decisions than is happening today. But that's just my presumption. So thank you very much for your attention to this presentation.
Okay, thank you. Thank you so much, Charles. We do have time associated vasculitis, some of which have been recently updated. So welcome to the course today, Dr. Geeta.
Thank you, Dr. Bombach and Dr. Radhakrishnan. Good morning, everyone. It is my real honor to be asked to speak at this conference. So my topic today is to go over the guidelines. Good morning, everyone. So my topic today is to go over the ANCA-associated vasculitis guidelines that have been published by EULAR and KDIGO more recently. I think 2 weeks back, there was a recent update. So these are my objectives. I'll review the recommendations made by KDIGO 2024 and EULAR 2022 pertaining to GPA and MPA. And then I will provide an overview of the trials and observational studies that provide supporting evidence for these recommendations. Obviously, no ANCA vasculitis talk will begin without introduction to the Chapel Hill nomenclature, which categorizes ANCA vasculitis as a small vessel vasculitis and includes 3 distinct clinical phenotypes: microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. As you already heard, the 2 main antigens against which the antibodies are formed are the PR3 ANCA and the MPO ANCA. So the first recommendation is to do with the diagnosis of ANCA vasculitis. And obviously, we know there are 2 main things we are going to be talking about. One, first is the ANCA testing, and the second one is the kidney biopsy. The EULAR 2022 states in patients with signs and or symptoms raising a suspicion for diagnosis of ANCA vasculitis, we recommend testing for both PR3 ANCA and MPO ANCA using high-quality antigen-specific assays as the primary method. KDIGO 2024 does not have any formal recommendation, and I will go over the evidence for this in a minute. In regards to the biopsy, EULAR 2022 states a positive biopsy is strongly supportive of diagnosis of vasculitis, and we recommend biopsies to assist in establishing a new diagnosis and for further evaluation for patients suspected of having a relapse. The KDIGO 2024 says in case of clinical presentation compatible with small vessel vasculitis in combination with a positive ANCA serology, waiting for a kidney biopsy to be performed or reported should not delay starting immunosuppressive treatment. So my own personal comment is kidney biopsy not only has diagnostic value, but is critical for prognostication, as you've already heard. So this is a study from Europe where they tested 294 ANCA vasculitis patients and over 900 normal controls for ANCA assay using 8 different immunoassays and 2 types of immunofluorescence assays. And what you notice here is a clear difference between the immunofluorescence assay, with one showing a high specificity and sensitivity for ANCA here for GPA. And here is the area under the curve for the 8 different immunoassays on top. And at the bottom, you see the 2 immunofluorescence assays, where you see a clear difference between the 2 immunofluorescence assays, and the antigen-based assay outperforms the immunofluorescence assays. So based on this, there was a revised consensus on recommendation for ANCA testing for diagnosis, which now recommends high-quality immunoassays as the preferred screening method to diagnose ANCA vasculitis. In other words, you order PR3 ANCA or MPO ANCA as opposed to testing by immunofluorescence. So while we are on this, I also want to note that not all patients who have a positive ANCA serology have ANCA vasculitis. There are certainly vasculitis mimics that we need to know. And this is a small retrospective French study which looked at all the positive ANCA serologies in their institution. And out of these, some of them had ANCA vasculitis, GPA and MPA, but what you notice is 99 of those patients, more than the 49 with ANCA vasculitis, had non-AAV diagnosis. Some of them were autoimmune diseases, and some of them are not even autoimmune diseases. This was a surprise, myocardial infarction, CVA, hematologic disorders. So the clinical context is really important when you interpret positive echo serology. So I mentioned that kidney biopsy is not only helpful for diagnosing, but also important for prognostication. And there are three main things that I want you to remember. The first is the burden classification, which is mostly began as a classification scheme where you classify ANCA-GN into 4 different categories based on the percentage of normal glomeruli or cellular crescents or globally sclerosed glomeruli into focal, crescentic, mixed, and sclerotic. For over long term, I think it is also shown to be helpful in prognostication. Focal class does the best, and sclerotic class does the worst. And the studies that have been validated really don't show a difference in outcome between the mixed and the crescentic so far, but that may have to do with the number of normal glomeruli that are seen on the biopsy. The second score is the Mayo Clinic Renal Pathology score, which is mostly a chronicity score because it takes into account global and segment glomerulosclerosis, if not arteriosclerosis. And the third one, which has been recently updated, is the Anca Renal Risk Score, which takes into account the kidney function at diagnosis and the percentage of normal glomeruli and the degree of interstitial fibrosis. So I think kidney biopsy, when possible, should be done, both at diagnosis and, if possible, during relapse, because it really helps to prognosticate. Moving on to the treatment, as many of you are aware, the treatment of ANCA vasculitis is divided into 2 different phases. The first is the remission induction phase, lasting for up to 6 months, and followed by the remission maintenance phase, which can last for a minimum of 24, and the maximum can be 48 or even longer months. So what are the options that we currently have for remission induction therapy? We use glucocorticoids along with either rituximab or cyclophosphamide, or a combination of rituximab and cyclophosphamide, and sometimes MMF. Avocapan is now become a treatment option, and Plex remains still a treatment option in select cases. So what do the guidelines say? EULAR 2022 says, for induction therapy in patients who have organ or life-threatening disease, they recommend a combination of glucocorticoids with either rituximab or cyclophosphamide. KDIGO 2024 also recommends glucocorticoids with cyclophosphamide or rituximab as the initial treatment for new onset ANCA vasculitis. Unfortunately, we have data to support each of these regimens because of completion of all these trials, the RAVE trial, the rituximab trial, and the Cyclops. Now, for relapsing disease, EULAR 2022 and KDIGO 2024 both recommend rituximab as the preferred agent, and the data for this comes from the RAVE trial. And in the cohort of patients that have severe presentations, serum creatinine greater than 4 milligram per deciliter, there is no recommendation from EULAR formally, but KDIGO 2024 recommends using either cyclophosphamide with glucocorticoids, or you can consider using a combination of cyclophosphamide and rituximab with glucocorticoids. And the evidence for this comes from the rituximab trial and some observational studies. So my own practice has now become, use rituximab for the majority and cyclophosphamide for 4 to 6 weeks, followed by induction course of rituximab when you have organ-threatening disease with serum creatinine greater than 5.7 milligram per deciliter or requiring hemodialysis at diagnosis. And so these are the 2 main trials that formed the basis of recommending rituximab. The first is the RAVE trial, which is the trial that was conducted in US, enrolled patients with severe GPR NPA, 197 patients. All patients received pulse methylprednisolone 1 gram daily for up to 3 days. And then they were randomized to get either rituximab 4 weekly infusions with placebo, cyclophosphamide pills, and no maintenance. And the other arm got cyclophosphamide oral with rituximab placebo and maintenance with azathioprine. Both arms received oral prednisone, which was tapered to 0 by 5 months. And the primary outcome in the RAVE trial was complete remission at 6 months, defined by a Birmingham vasculitis vaginous granulomatosis score of 0 and a prednisone dose of 0. Now, in the rituximab trial, again conducted by Europe, they enrolled patients and randomized them to either receive IV cyclophosphamide along with glucocorticoids, followed by azathioprine for remission maintenance. And the experimental arm got glucocorticoids along with rituximab plus 2 IV doses of cyclophosphamide. The primary outcome in rituximab was sustained remission and rates of severe adverse events at 12 months. So there are important trial differences that I do want you to know between the two trials. In the RAVE trial, it excluded patients with a serum creatinine greater than 4 milligram per deciliter. Rituximab allowed patients who were even dialysis dependent on entry. In RAVE trial, the rituximab arm did not get any cyclophosphamide. In rituximab, the rituximab arm got 2 doses of cyclophosphamide. And in RAVE trial, prednisone was stopped at month 5, whereas in rituximab, they were continued on 5 milligram of prednisone until month 12. Now, looking at the outcomes, short-term efficacy, the primary outcome at month 6, rituximab was non-inferior to cyclophosphamide in the RAVE trial. And in rituximab, the sustained remission rate with no difference between the rituximab and the cyclophosphamide arm. And if you look at the long-term efficacy, the sustained remission rate at 18 months, really very low. Only about 40% of the patients remained in remission in the RAVE trial. And if you look at rituximab, the relapse-free survival was 73% in the rituximab arm and 90% in the cyclophosphamide arm. And when you look at adverse events, this is even more important. Really, it did not make a difference whether you use cyclophosphamide or rituximab, which kind of tells you that maybe the main player in terms of adverse events could be the glucocorticoids. Now, this is the data that supports the use of preferentially using rituximab for patients with relapsing disease and PR3 Anca disease. The left side is the data from RAVE trial, which shows that in patients who have relapsing disease, the red shown in rituximab is superior to cyclophosphamide shown in blue for achieving remission. On the right side is the table, which shows the PR3 patients that are treated with cyclophosphamide versus rituximab achieving remission. And what you notice is if you look at all patients treated with rituximab have a superior relapse-free survival at 6 months compared to cyclophosphamide, but it fades off at month 12 and month 18. However, at the bottom, you see PR3 Anca patients who have relapsing disease. And in those patients, rituximab is superior to cyclophosphamide for maintaining remission at month 12 and at month 18 as well. And it's for this reason that rituximab is now preferentially recommended to use for remission induction in patients who have relapsing disease as well as PR3 Anca positive. Now, the trial that formed the basis for recommending cyclophosphamide for remission induction, the Cyclops trial, a European-based trial, which randomized patients who have a new diagnosis of ANCA-associated GN to receiving either pulse IV cyclophosphamide or oral cyclophosphamide, and the primary outcome was remission at 9 months. Again, what you see is no difference in remission between IV and oral cyclophosphamide. However, the cumulative dose of cyclophosphamide was double in the oral arm, 16 grams compared to 8 grams in the IV arm, and therefore a higher incidence of leukopenia in the oral cyclophosphamide arm. And if you look at the long-term outcomes, the relapse risk was significantly lower in the oral cyclophosphamide group. Now, where does the data from combining rituximab and cyclophosphamide come? There are no trials that address this particular phenotype, severe renal disease. This is an observational study from the Imperial Group in the UK, and they've also replicated this at MGH here. They enrolled patients, 64 patients with severe disease with the eGFR at entry of 9 mLs per minute. 47% of the patients were dialysis dependent. Over half of the patients had alveolar hemorrhage. And they were treated with plasma exchange up to 10 sessions every other day. Intravenous cyclophosphamide for a cumulative dose of 3 grams, given as 500 milligrams. And rituximab, 1,000 milligrams for 2 doses. The cumulative oral prednisone was 2.6 grams, median follow-up of 46 months. With this regimen, 94% of the patients achieved remission by 6 months. 67% recovered from dialysis-dependent kidney failure. There was an 85% patient survival at 46 months. And KDIGO 2024 also gives you a list of preferences where you can use rituximab versus cyclophosphamide. The main things are rituximab is preferred in patients who are young, in premenopausal women, in frail old adults. and glucocorticoid sparing is important in those with relapsing disease and PR3 Anca, and cyclophosphamide is the preferred choice when you have severe presentation, which is life or organ threatening, and when rituximab is difficult to access. Moving on to steroids. Again, I think we now have data to support a reduced dose glucocorticoid regimen. We are fortunate to have completed all those trials. In terms of pulse methylprednisolone, there is no evidence. So EULAR 2022 says there is no compelling evidence to support routine use of pulse methylprednisolone in addition to oral glucocorticoid treatment for induction treatment. Based on evidence from Plexivas, pulse prednisolone should be limited to treatment of severe organ-threatening manifestations. KDIGO 2024, also there is no formal recommendation, but it does mention that intravenous methylprednisolone is widely used initially for patients with more severe presentation at a dose of 1 to 3 grams in total, and again notes that the approach is not evidence-based. Coming to oral glucocorticoids, both the EULAR 2022 and KDIGO 2024 recommend using the reduced dose Plexivas protocol for the oral prednisone dosing, and I will go over the Plexivas trial in a minute. And in terms of the tapering, there is no formal recommendation from the EULAR on tapering based on cyclophosphamide or rituximab-based induction, whereas KDIGO 2024 says following cyclophosphamide induction, prednisone can be reduced to 5 milligram daily by 6 months, and following rituximab induction, prednisone can be stopped by 6 months. So what you also need to notice in RAVE, LOVAS, and ADVOCATE trial, prednisone was stopped at month 5, and in Plexivas, patients were maintained on 5 milligram of prednisone till week 52 and beyond, as per discretion of the treating physician. In my own practice, most of the patients, I stop prednisone at month 5 unless there is a real strong reason for continuing, which means I'm unable to give maintenance therapy for one reason or the other with rituximab, azathioprine, or mycophenolate. So I'm going to go over the Plexivas trial, which is an international trial, which is the largest trial enrolling 704 patients, and it tested 2 different interventions, the use of Plex versus no Plex, and the use of standard dose glucocorticoid and reduced dose glucocorticoid. The median follow-up was 2.9 years. The cumulative oral dose with reduced dose glucocorticoids was 44% and 60% lower than current standard therapy at 3 and 6 months. And the primary endpoint was the composite of death or ESRD from any cause, which was no different between the standard dose and the reduced dose glucocorticoid dosing. However, there was significantly reduced severe infections at 1 year in the reduced dose arm. Of note, Plexivas predominantly enrolled cyclophosphamide-induced patients. Only 15% of the patients were in the reduced dose glucocorticoid group who received rituximab. And although reduced dose glucocorticoids was effective in decreasing infections, serious infections still occurred in up to a third of the patients. So we still have room to improve here. The second study, which is actually a Japanese study which used rituximab-induced patients as opposed to Plexivas to test a glucocorticoid regimen, is the LOVAS study. It enrolled 140 patients. Most of them were MPO Anca positive. They were all induced with rituximab and randomized to high dose, which is a starting dose of 1 milligram per kilo per day. At month 5, they were tapered to 10 milligram. The median eGFR at entry was 55 milliliters per minute, or reduced dose where the starting dose was 0.5 milligram per kilo per day. At month 5, tapered to 0. Median eGFR was 52 milliliters per minute. And the primary outcome was complete remission at 6 months. So here the reduced dose glucocorticoid was non-inferior to standard dose for achieving remission. And in terms of cumulative dose, you would notice that the reduced dose was 1.3 grams versus the standard dose of 4.1 grams. And when you look at adverse events, if you look at the patient visual analog scale for treatment toxicity, it was significantly lower in the reduced dose glucocorticoid arm. And if you look at other adverse events, there was no statistical significance, but numerically lower serious adverse events and serious infection in the reduced dose glucocorticoid arm. Moving on to the controversial topic of plasma exchange for remission induction therapy. This has been the major update in KREGO, one of the major updates in KREGO 2024. So the EULAR 2022 says plasma exchanges may be considered as part of treatment to induce remission in GP and MPA for patients with serum creatinine greater than 300 micromoles per liter due to active glomerulonephritis. Routine use of plasma exchange to treat alveolar hemorrhage is not recommended. KREGO 2024 now recommends considering PLEX for patients with serum creatinine greater than 3.4 milligrams per deciliter, those requiring dialysis or rapidly increasing creatinine, and in patients with alveolar hemorrhage or hypoxemia. And the evidence for this comes mostly from the meta-analysis that was published in 2022. The other recommendation pertaining to PLEX is both EULAR 2022 and KREGO 2024 recommend using PLEX when you have double positive disease with positivity for both Anca and anti-GBM, and that comes from observational studies. So my own practice, I still use PLEX, mostly in patients who have serum creatinine greater than 5.7 milligram per deciliter or requiring dialysis with a biopsy. I think kidney biopsy is really important here. With a biopsy revealing minimal chronic changes, and also use PLEX for those that have refractory Anca-GN and those with double positive disease. So here is the data on PLEX. Again, looking at the primary outcome of death from any cause at ESRD, no difference between plasma exchange group and no plasma exchange group. And when here is a recently published sub-analysis or post-hoc study of patients with alveolar hemorrhage, about a third of the patients in the Dupixent had alveolar hemorrhage. And what you see here is the death at 3 months and 1 year. In patients who had alveolar hemorrhage and without alveolar hemorrhage, and in patients who had severe versus non-severe alveolar hemorrhage, PLEX clearly had no real effect, no significant effect on either the alveolar hemorrhage or the severity of alveolar hemorrhage. And if you look at the number of ventilator-free days, again, no difference between PLEX and no PLEX arm. So based on this, EULAR recommended no PLEX for alveolar hemorrhage, but KDIGO says consider PLEX just because of the higher mortality rate in patients who have alveolar hemorrhage. And here is the meta-analysis of about 9 trials which had information on end-stage kidney disease on 999 patients. It showed that PLEX reduced the risk of ESKD by at 12 months with a relative risk of 0.62. And the absolute risk reduction in patients with a creatinine greater than 3.4 milligram per deciliter was about 4.6%. And in patients who had a serum creatinine greater than 5.7 milligram per deciliter was 16%. But what you also notice in the bottom is concomitantly, there was a higher infection risk in both of these groups. So based on the meta-analysis, there was an updated clinical practice guideline. They stratified patients with kidney disease into 4 different groups based on their entry serum creatinine and the risk of developing ESKD at 1 year, low to moderate, moderate to high, and high risk groups. And they wanted to come up with 4 recommendations, 3 pertaining to PLEX and 1 pertaining to glucocorticoid dosing. And these are the recommendations. So there is a weak recommendation in number 2 to consider PLEX. So number 2 is the patients who are moderate to high or high risk of developing ESKD or requiring dialysis. So there's a weak recommendation based on the meta-analysis. Moving on to this, the second important update in the KREGO 2024 and also in the EULAR 2022 is the use of avocapan. So avocapan in combination with rituximab or cyclophosphamide may be considered for induction of remission in GPR MPA as part of a strategy to substantially reduce exposure to glucocorticoids. And this is the recommendation in both, but in KREGO 2024, it also mentions patients with lower eGFR may benefit from greater eGFR recovery, and I will show you the data for that. And the evidence, so my own practice is I offer avocapan, I will say to almost all patients, because I don't think anybody can say that there is nobody who will benefit from reducing steroids. So, but mostly in patients who are at high risk for glucocorticoid toxicity, I've been using them, and also in patients with low baseline GFR at entry, I think avocapan is a very attractive option. So the Advocate trial is the phase 3 trial, which supports the evidence for using avocapan. Again, it was an international trial which enrolled patients with severe GP or MPA and stratified them based on their baseline induction therapy, cyclophosphamide versus rituximab, Anca type, PR3 versus MPO, and newer relapsing disease, and then randomized them to either get avocapan 30 milligram BID with placebo prednisone or prednisone with placebo avocapan. And prednisone was tapered to 0 at week 20. The cyclophosphamide arm here received azathioprine for remission maintenance, whereas the rituximab arm did not receive any remission maintenance because at the time the trial was actually, protocol was formed, the maintenance trials were not out. They enrolled 330 patients, 57% were MPO-ANCA positive, 81% had renal vasculitis, 2/3 were induced with rituximab, 1/3 with cyclophosphamide. They had 2 different primary outcomes: complete remission at week 26 and sustained remission at week 52. Now, complete remission was defined as a Birmingham Vasculitis Activity Score of 0 and no prednisone use in the preceding 4 weeks. It was a non-inferiority margin was 20. And what you see is at week 26, avocapan was non-inferior to steroids for remission induction, 72% in avocapan arm and 70% in the glucocorticoid arm achieved remission. And at week 52, avocapan was superior to steroids for remission, for sustained remission. 66% of patients in avocapan arm were in sustained remission compared to 55% in the steroid arm. More importantly, the reason we are here, the eGFR recovery was really excellent. So if you looked at the entire cohort at week 52, the avocapan arm had a 3.2 milliliter higher eGFR recovery. And if you look at the subset of patients who had a GFR less than 30 milliliters per minute, it was even higher, 5.5 milliliters per minute higher compared to prednisone. And GFR less than 20, which is the real sick group, the GFR rise was 8.4 milliliters per minute. So among patients with eGFR less than 20 at entry, significantly higher number of patients in the avocapan arm had their last GFR rise greater than 2-fold higher than baseline compared to the prednisone arm. So the eGFR recovery is really interesting and very attractive for us. There are 2 important secondary outcomes that I will focus on. The avocapan arm also showed a lower reduced relapse risk compared to the prednisone arm. And one of the main criticisms of the study is that, in the avocapan arm, avocapan was continued till week 52, whereas in prednisone arm, prednisone was stopped at week 20. But actually, if you look at the curves, the relapses start occurring in the glucocorticoid arm even before week 20, which kind of says that maybe there is a role for avocapan, to maintain remission. But again, we need the study to have more evidence for that. The second most important secondary outcome is the quality of life. And what you see is the week 26 and the week 52 quality of life scores. The red is the avocapan curve. The one on top of that, the purple is the normal age and gender match controls. And the one below that in gray is the steroid arm. And what you see in each domain, the avocapan arm had a higher quality of life improvement score compared to the prednisone arm. So when do we stop immunosuppression after induction therapy? So there is no formal recommendation from EULAR 2022, but KDIGO 2024 says that when you have patients with renal limited disease, discontinue immunosuppression after 3 months in patients who remain on dialysis and who have no extrarenal manifestations. And the evidence is mostly based on observational studies and meta-analysis. The bottom line is a recent meta-analysis that was published in Seminars in Arthritis and Rheumatism, where they looked at 22 studies, 952 patients with ANCA vasculitis on dialysis, and they looked at mortality rate, relapse rate, and severe infections. Obviously, very high mortality rate, 10.9 per 100 person years. Severe infection rate, 66.6 per 100 person years, but a low relapse rate, 6.2 per 100 person years. How about non-organ threatening disease? In EULAR 2022, again, they recommend treating with a combination of glucocorticoids or rituximab. They also recommend using methotrexate or mycophenolate as alternatives to rituximab. In KDIGO 2024, which is kind of a modification, the recommendation is now to use rituximab with either glucocorticoid taper or avocapan, or cyclophosphamide with glucocorticoid taper or avocapan. And the evidence for this comes from 2 European trials, the MISEC trial and the NORAM trial. My own comment is methotrexate and MMF are non-inferior to cyclophosphamide in non-organ threatening disease for remission induction. However, relapse rates were high compared to cyclophosphamide, and hence they should be reserved for patients who have contraindications to rituximab and cyclophosphamide. Here is the MISEC trial, which compared using IV cyclophosphamide to MMF for remission induction in patients with ANCA vasculitis, new diagnosis. The blue is the MMF, orange is the cyclophosphamide. No difference in the 6-month remission rates. However, if you look at the relapse rate, significantly higher relapses in the MMF arm compared to the cyclophosphamide arm. And most of these were actually in the NPO ANCA patients. Now, coming to refractory vasculitis, both EULAR 2022 and KDIGO 2024 do recommend, doing a thorough assessment of the disease status and comorbidities and considering different treatment options and referral to a vasculitis expert center. So basically the choices are includes glucocorticoids. If you use rituximab for induction previously, change it to cyclophosphamide. If you use cyclophosphamide, change it to rituximab. KDIGO 2024 also recommends using Plex if you have refractory vasculitis, but that's not mentioned in the EULAR 2022 guidelines. There is no evidence because we have no trials for ANCA vasculitis with refractory disease. Moving on to maintenance therapy. For EULAR 2022, the maintenance regimen says after induction with rituximab or cyclophosphamide, they recommend maintenance treatment with rituximab. Azathioprine or methotrexate can be considered as alternatives. For KDIGO 2024, it recommends either using rituximab or azathioprine with low-dose prednisone after induction of remission, and also says consider MMF or methotrexate who are in patients who are intolerant of azathioprine. There is also a note made in KDIGO 2024 that following rituximab induction, maintenance immunosuppression should be given to most patients. And this was probably made because there is an idea among many experts that patients who have NPO ANCA disease and who have achieved remission using rituximab may not need maintenance immunosuppression, which I think is not necessarily true. And so I think following rituximab induction, most patients will need maintenance therapy. The evidence for all of these comes from, again, multiple randomized trials, maintenance and rituximab, cyclosarum, and Vigent trials. In my own practice, for maintenance therapy, majority of them are maintained with rituximab, and azathioprine is used in patients who are intolerant, and MMF is the third line in patients who are intolerant to azathioprine and rituximab. And the evidence for rituximab comes from these rituximab-based trials, the maintenance 1, 2, 3, and the rituximab. So here is the trial, the maintenance 1 trial enrolled patients who had new diagnosis and who achieved remission following cyclophosphamide induction. Then they were randomized to receive oral azathioprine 2 mg per kilo per day, or rituximab 500 mg, 2 doses given at month 6, followed by 500 mg every 3 months for up to 3 more doses. And the primary outcome was the major relapse rate. And what you see here is significantly lower relapse rate in the rituximab arm compared to the azathioprine arm. At month 60, rituximab was still superior to azathioprine. However, after rituximab discontinuation, 42% of the patients relapsed. So it's important to note, no matter what immunosuppression you give, when you stop, a significant proportion of patients will relapse. Here is the rituximab trial, which enrolled patients who had relapsing disease, who then achieved remission using rituximab for remission induction. Then they were randomized to either get azathioprine 2 mg per kilo per day, which was tapered and stopped by month 27, or they received rituximab 1,000 mg beginning at month 4, every 4 months for 5 doses. And the primary outcome was the relapse rate at 24 months. What you see in blue is rituximab and pink is azathioprine. rituximab had a superior relapse-free survival both at 24 months and at 48 months. In terms of therapy duration, EULAR 2022 recommends maintaining maintenance therapy for 24 to 48 months following induction remission of new onset. KDIGO 2024, which is a change from the previous one, says 18 months to 4 years after induction of remission. I think in 2021, it mentioned 18 to 24 months for azathioprine and 18 months for rituximab. The evidence for this comes from MAINTENANCE-3 and the REMAIN trial. And EULAR 2022 also says longer duration of therapy can be considered in patients with relapsing disease and those who have high risk for relapse, but should be balanced against patient preferences and risk of continuing recommendation. And there is no other recommendation from the KDIGO 2024. In my own practice, I think this needs to be really personalized based on renal function, disease severity at initial presentation, the Anca type, P3 or NPO, whether they achieved Anca negativity at remission, achieved induction, and history of relapsing disease. So this is the MAINTENANCE-3 trial. So basically in MAINTENANCE-3, what they did was the top left, the first panel is the MAINTENANCE-2, which tested scheduled versus tailored rituximab infusions. And once they completed the MAINTENANCE-2, then they were allowed to participate in MAINTENANCE-3, which extended treatment with fixed dose rituximab 500 milligram every 6 months for another 4 doses or gave placebo infusions. And what you see is when you extend the fixed dose rituximab treatment, the relapse-free survival was superior, 96% versus 74% in the placebo arm. How about for the azathioprine? The data for this comes from REMAIN trial, which is a European vasculitis group conducted trial, which enrolled 117 patients who achieved remission after induction with cyclophosphamide. Complete data was available on 110 patients. 52 had GPA, 59 had MPA. In 59 patients, azathioprine was continued until month 48. In 51 patients, azathioprine was withdrawn at month 24. And here's the relapse-free survival. 2.8-fold higher risk of relapse in the withdrawal arm compared to the continuation arm. The other point that is kind of focused is the role of Anca and CD19 monitoring in dictating or tailoring the remission maintenance therapy using rituximab. In EULAR 2022, it says we recommend structured clinical assessment rather than Anca and CD19 monitoring to inform decisions on changes in treatment. There is no recommendation from the KDIGO 2024, and the basis for EULAR recommendation comes from the MAINTENANCE-2 trial. My own practice, I think, I use scheduled rituximab every 6 months for up to 24 or 36 months, depending on disease severity at presentation, and then give tailored rituximab based on the relapse risk profiles, serum immunoglobulin, and other comorbidities. Here is the MAINTENANCE-2 trial, which enrolled patients who achieved remission after using mostly cyclophosphamide, some with rituximab, and one with methotrexate, randomized to get 500 milligrams of rituximab at day 14 and at day 0 and 14, and then every 6 months for 3 doses, or they got rituximab based on Anca converting from negative to positive, or a 2-fold increase in titer, or CD19 reconstitution defined as CD19 greater than 0. And what you see here is relapse-free survival was really not different between the fixed and the tailored arm. But what you also notice, the number of infusions was lower in the tailored arm. However, although not statistically significant, relapses were numerically higher in the tailored arm. More importantly, no difference in adverse events, even though the infusions were less in the tailored arm. And an important observation is that even in patients who were Anca negative, and even in patients with CD19 was 0, there was a proportion of patients that relapsed. So this is a recent publication of the MAINTENANCE pooled trials. They pooled all the MAINTENANCE 1, 2, and 3 patients and looked at the relapse-free survival. And what you see here, I'm trying to see if I can point to, sorry. So this one here at the bottom is the azathioprine arm. One second. This is the azathioprine arm, and what you see here is the tailored rituximab arm in purple, and on top in yellow is the fixed 18-month rituximab. So the relapse-free survival was significantly lower in azathioprine and tailored 18-month rituximab compared to the fixed 18-month rituximab. But let us look at the fixed 18-month compared to the 36 18-month. There was really no difference. And I've showed this in the table here. Azathioprine at 49% relapse-free survival. Tailored rituximab at 18 months, also 49%. If you looked at fixed rituximab, it was 70%. If you looked at fixed rituximab at 36, it was higher, but not statistically significant. I don't know whether you could see this well, but this is the treatment algorithm by the KDIGO 2024. Once you make a diagnosis of ANCA vasculitis, if you have vital organ or life-threatening serum creatinine greater than 3.4 milligram per deciliter, the recommendation is to do rituximab plus cyclophosphamide or cyclophosphamide with glucocorticoid or avocapan and consider plasma exchange. If you have non-organ threatening, you can use rituximab with glucocorticoid taper or avocapan, or cyclophosphamide with glucocorticoid taper or avocapan. And once you have the disease under control, then you can either continue rituximab for remission maintenance or give azathioprine, and then you stop them and monitor them on off treatment. Withdrawal of immunosuppression, really there's no formal recommendation from EULAR 2022. KDIGO says consider withdrawing immunosuppression, but the risk of relapse should be considered and the patient should be informed of the need for prompt attention if symptoms occur. So what are the factors that you take into consideration? The baseline factors that predict who's at high risk of relapse. If you have a GPA phenotype, if you have the PR3 ANCA serotype or low serum creatinine, ENT disease, you're going to be at a higher risk for relapse. If you've already had a risk of relapse, if you remain ANCA positive at the end of induction treatment, or there is a persistent rise in ANCA, again, it says you are at high risk of relapse. Again, trials have showed if you have lower cyclophosphamide exposure, as in the long-term or follow-up of the cyclops trial, or if you have immunosuppressive withdrawal or glucocorticoid withdrawal, there is a higher risk of relapse. In terms of monitoring of immunoglobulins during treatment of rituximab, because hypergammaglobulinemia is a significant side effect of long-term rituximab use, there is no recommendation from KDIGO 2024, but EULAR 22 recommends measuring serum immunoglobulins prior to each course of rituximab to detect secondary immunodeficiency. And there is some data about the incidence of this from Manditsand-3 and rituximab. In my own practice, I do routinely check immunoglobulins every 4 to 6 months, and evaluation for secondary immunodeficiency is initiated when IgG is less than 300, and rituximab is held and alternatives are considered in patients with severe hypergammaglobulinemia and the history of recurrent infections. So here is the incidence of hypergammaglobulinemia in the Manditsand-3 trial. At the bottom, you see at the trial end, 21% of the patients in the rituximab arm had IgG less than 5 grams per liter. And in the rituximab trial, about 42% of the patients in the rituximab arm and 31% in the azathioprine arm had IgG less than 5 grams per liter. In terms of infections, for patients receiving rituximab or cyclophosphamide and steroids, EULAR recommends use of trimethoprim sulfamethoxazole as prophylaxis for PJP and other infections. There is no formal recommendation from KDIGO 2024, but does note that trimethoprim or alternatives should be considered for PJP prophylaxis for duration of cyclophosphamide use or 6 months after rituximab infusions. The evidence for this comes from observational studies and the RAVE trial. My own practice, I prescribe trimethoprim sulfamethoxazole for the first 6 months after induction and then continue based on sinus disease, pneumonia, IgG level, and CD4. And here is the observational data using cohort of patients from Cambridge group at Innsbruck, 198 ANCA vasculitis patients who were treated with rituximab. 38% of them were on Bactrim or trimethoprim sulfamethoxazole. The mean follow-up from the first rituximab infusion was 23 months. What you see in the Kaplan-Meier curves is the time to first infection was significantly less in those that were on Bactrim. And here is data from the RAVE trial, in which 180 of the 197 patients received trimethoprim sulfamethoxazole. And what you see is the infection-free survival was significantly better in those that were on trimethoprim sulfamethoxazole. The last recommendation is about kidney transplantation. There is no formal recommendation from EULAR 2022, but KDIGO 2024 says delay transplantation until the patient is in clinical remission for at least 6 months or longer. Persistence of Anca should not delay transplantation. Again, these are all observational study evidence. In conclusion, we now know there is evidence-based guidance on management of Anca vasculitis. PLEX continues to have a role in severe ANCA-associated GN. Avocapan use is associated with improved remission rates, lower glucocorticoid toxicity, lower glucocorticoid dose, and better kidney function recovery. Personalization of maintenance therapy duration remains an unmet need. Other unmet needs includes optimal induction treatment for severe renal disease. No trial has really addressed it. Personalization of maintenance therapy, identify reliable markers to assess subclinical disease activity is quite important. Again, biomarkers to assess relapsing disease, and then studies looking at long-term outcomes after induction therapy with avocapan and avocapan alone in maintenance therapy are also required. I'm going to stop here. Thank you for your attention. Happy to take any questions.
Okay, thank you so much, Dr. Geeta. We're going to move to our next talk now, welcoming Dr. J. Radhakrishnan, who's co-director of this course, also professor of medicine here at Columbia, and the clinical chief of nephrology.
Thank you, Andy. And, the preceding talks have really laid the groundwork for my section, which is to do with B-cell therapies in ANCA-associated vasculitis. So a lot of what I'm going to talk about has been said, but I think I shall focus on certain aspects and nuances of how we manage patients with B-cell therapies. So we'll talk very briefly what the role of the B-cell is. Dr. Falk laid the groundwork very beautifully in the pathogenesis section, and what are the targets that we can use to control disease. A couple of pivotal clinical trials that Dr. Geeta has spoken about, and then most importantly, practice points. How do we use B-cell therapies, in a sort of strategic fashion, if you will, in managing these very difficult patients? And finally, what's on the horizon in terms of what else can we do with targeting the B-cell? So the whole pathogenesis of ANCA used to be thought that you have antibodies and they rev up neutrophils, which then releases cytotoxic chemicals causing damage. But there's a whole back-end story here, both innate and adaptive immunity that Dr. Falk had spoken about, where T cells and dendritic cells, they all come into play, they form granulomas, and within injured tissue, they actually can form germinal centers with B-cell and B-cell derived cells. So the point here is that the B-cell is integral to the pathogenesis of ANCA vasculitis, and targeting the B-cell makes complete sense in trying to manage disease. So when you look at the B-cells, there are a number of targets that one can use in controlling B-cell function. So when you go from the pro to the pre-B-cell to immature B-cells, and finally the mature B-cells, the activated B-cell, and then finally the antibody-producing cells, which are essentially plasma cells. And there's this set of B-cells called long-lived memory cells, which are very important, because once they gain recognition of the antigen and they have the capacity to produce antibody, even if the disease is in remission. So you can see CD20 is there in the majority of B cells, but not in the antibody secreting cells. Whereas the main main sort of surface protein in this section is the CD38, which, as we know, is a target for myeloma therapy. And also very important is when B cells get activated, there are survival factors, and there are receptors on B cells that, when the survival factors engage, will cause propagation of B cells along this pathogenic flow to maintain active B cells, which are essentially producing antibodies. And we'll talk about this in some detail as we go along this lecture. So in immunology, we are in a perfect situation because there's a lot of options right now. We have a whole bunch of CD20 antibodies. We have the anti-survival factor antibodies. We also have a very good repertoire of CD38 antibodies. And how can we sort of use this in managing patients with autoimmune disease? And that's obviously going to depend on clinical trials. So rituximab was the foremost in this category, and the way it works is it binds to CD20, and it leads to direct apoptosis of these cells. But there's also a complement-mediated lysis. So this is equally important in causing damage to the B cell and depletion subsequently. So I won't go over the pivotal clinical trials that led to the widespread use of rituximab and FDA approval, but there are some aspects of these trials that we need to be cognizant about. And we know about the RITUX-VAS and the RAVE trials, and these were the RITUX-VAS was a small trial. The patients were much sicker. You can see the GFR was 18. And what is notable is that your remission rates was not 100%. So about 2/3 to approximately half the patients went into a BVAS of 0, which is remission. So it's not by any means a uniformly effective drug in combination with steroids or in combination with cyclophosphamide. And most importantly, these trials had a very significant rate of adverse events, and in fact, even death, especially in the rituximab study. So the key here is that we have very good therapy. It's not perfect. It's got a very high side effect profile, probably largely because of corticosteroids. So any adjunctive therapy that we look for in the subsequent years are looking at trying to reduce or even eliminate corticosteroids. And Andy Bomback will give a nice talk on the role of complement in trying to abrogate some of the side effects from corticosteroids. And of course, there's not only do we have imperfect remission, but there's also a significant relapse rate. So I'm going to view this as a cup half empty rather than a cup half full, because we have good therapy, but it's by no means perfect in this current day and age. And the pivotal trial that led to rituximab use in the maintenance aspect of Anca vasculitis was the main RITSEN trial, where patients were randomized to rituximab versus azathioprine. And again, you look at relapse rates. So when they're on rituximab, it's quite low. This is inverse, sorry. And then equally importantly, they have an equal adverse event profile. So you can look at this, the curves on the top is that actually patients who are on continuous rituximab, they do quite well versus azathioprine, who tend to relapse, both major and minor. And the other important thing, as was pointed out, was when you stop rituximab, your relapse rate starts to climb up, even in the rituximab group. So this is by no means a guarantee that when you go into remission and you're on maintenance and you stop maintenance, you are not going to relapse. So vigilance is important. We are hoping that there'll be biomarkers of, or even genetic markers of prediction of relapse, because putting people on long-term therapy for 4 to 8 years, from 3 to 5 years is not easy. So then we come to practice points. And in this, I'll discuss some of the nuances and how we use B-cell therapies to control patients. So in 2024, all I can say is that the majority of patients during the induction phase probably should be on rituximab. And so I'm not going to go into the area where it's preferred. I'm going to say in most patients, Ritux should be preferred. But there may be instances where cyclophosphamide might be preferred, and that's essentially mainly to do with access. And if you are looking at cyclophosphamide, it's probably best used in conjunction with rituximab in the most sick or the most sort of aggressive ANCA vasculitis, which is typically people with rapidly rising creatinine or near dialysis levels of creatinine, and especially with people with diffuse pulmonary hemorrhage. So my sort of take on this whole data analysis of data is that the drugs are equivalent, but it's much easier to use rituximab versus cyclophosphamide where available. And you can go either into the 375 milligrams per meter squared per week times 4 weeks, or a gram at baseline and at 2 weeks. And then if you're planning to use cyclophosphamide, it's 15 milligrams per kilo based on the RETUX-VAS trial, and that can be given in 2 doses at weeks 0 and at weeks 2. So coming to maintenance therapy, again, there's probably highly preferred that rituximab be used for maintenance therapy as well. You saw the data. And there may be instances where azathioprine might be preferred, and these are patients with hypogammaglobulinemia, as we saw in the previous lecture, and again, mainly to do with access, that it's not available or in a country that we practice, right? So how much do we give? We can give, based on the data, 1,500 milligrams times 2 at remission, and then you give 500 milligrams during the maintenance phase. That's a main Ritson study, or you can give 1,000 milligrams after you induce remission, and then 4, 8, 12, and 16, you can continue this dosing. So there's no hard and fast rule here. What I typically do in my patients is, and we'll see this in the subsequent slide, is to use a B-cell depletion strategy, which may be more convenient and more economical, especially if rituximab is expensive and you're paying out of pocket, right? So here's the question about a fixed versus a tailored regimen. And what do you mean by that? A fixed is you take patients' remission, you give them rituximab at a fixed schedule. So in this study, main Ritson 2, as you saw, you give 2 doses, 0 and 14 days, and keep going the same dose every 6 months for a total of 18 months. And that's fixed. If you go for the tailored regimen, you look at the B cells or Anca that have reappeared, or from 0 to a positive Anca, or if you've never lost the Anca, you're seeing a rapid rise in Anca. And if you look at the studies, there are some definitions. It's 4 to 5 times higher than baseline. So if they're going up in a hurry, you then put them into this so-called tailored regimen. And then in that case, you give them 500 milligrams when either of these events happen. And you can see there's a marked reduction in the number of doses used. There's an approximate halving if you use a tailored regimen. So one needs to be a little careful in defining, your tailored regimen, because there are very fixed criteria that is used in this trial. So please do refer to this slide or to the paper when you decide to use a tailored regimen. In my own sort of practice, I use a B cell count of 0, and if it starts to go up higher than 0, then I give them another dose. If you look at outcomes, they were identical in the 2 groups with a much lower requirement for rituximab in the tailored regimen. And then how long? And again, this was shown before, but in main Ritson 3, you take 2 main Ritson 2 fixed and tailored, and then you randomize them into no rituximab versus ongoing rituximab, 500 milligrams every 6 months for another 28 months. So the total time is about almost 5 years. And you can see right here, if you stop rituximab, you do have a risk of relapse, right? But again, 20% of patients are going to relapse, so your number needed to treat is quite significant. So you have to be careful that, or what I typically do is I look at sort of risk factors for relapse, and the biggest ones are PR3 positive, and especially if a patient comes with lung involvement. But every patient is at risk for relapse, and there's no sort of checkbox saying this patient will or will not relapse. And the other question is, look, we have patients who've got sort of an Anca titer that's going up without any clinical manifestation, versus like I might say, look, let's look at the B cells, and during a fixed interval, the moment you reconstitute B cells, you want to give the rituximab. So there are 2 different questions asked. So the previous slide, we showed either or, but here you're randomizing patients after going to remission into an Anca flare group versus without clinical manifestations, or for a B cell reconstitution group. And they use a threshold of 10 cells per millimeter cubed for a reconstitution, and Anca flare, as discussed, this study has its own criteria as well. And at the time of emergence of any of these, you'll get a gram of rituximab for the reconstitution group, and you'll get 2 doses of Ritux, 1,000 milligrams for the flare group, Anca flare group. And you can see from the data that the Anca flare If you wait for an Anca flare, it's actually do much worse in terms of relapse rates. But if you control the B cells, they do much better. So I think if you were to choose a strategy, look at B cell reconstitution and redose them if it happens. But you have to be especially careful in terms of monitoring, not only clinically, but for a B cell count that you need to send every 2 to 3 months during the course of this follow-up. Then the other situation is relapsed ANCA, and again, rituximab is preferred. And you can see from this study, RITAZERM study, that by month 4, in patients who had previously was treated and they come back in relapse, rituximab is really very effective. So 90% of patients have a BVAS less than equal to 1 at 4 months. So any relapse patient, again, should be considered as being candidates for rituximab therapy. And if you look at move these patients into maintenance, again, rituximab is much better than azathioprine. But if you stop rituximab, again, there's going to be a risk of relapse. So the game isn't over when you stop maintenance therapy. So in refractory disease, again, it's a little nebulous. What is refractory disease? I mean, you can say any BVAS above 0 is refractory disease. And in such patients, especially if they have significant organ involvement, if they've been on a tapering dose of steroids, one would say let's give them a boost. The other small trials that have come out, not really trials, but more clinical experiences, is the use of avacopan in these patients in the setting of refractory disease. And if they had been previously on, say, cyclophosphamide, and it's time to use rituximab, and vice versa. And again, in very severe refractory disease, you can pull your plasma exchange card and hopefully get them into remission. But in the current day and age, with the treatments we have, the chances of truly refractory disease is not very high. There may be lingering disease or persistent disease. And if one's not sure that the kidney is really not suffering from, say, glomerulosclerosis causing proteinuria, it might be worth doing a biopsy if everything else is quiet and ANCA titers are coming down nicely. But there's some residual proteinuria, which might not be because of active vasculitis. So a biopsy may be preferred to qualify whether this patient is truly refractory. A big important point with rituximab is the box warning. And the biggest box warning is infusion reactions. And you have to learn to understand what this means, right? I'll discuss this in some detail. The other big one, of course, is Hep B. And I'll give you some guidelines how to manage a Hep B positive patient. And then the feared progressive multifocal leukoencephalopathy. Is it common? I mean, how do we sort of look for it? So when you look at reactions, everyone who gets rituximab will get a reaction to some extent, and maybe a little itching or mild reactions to the most fulminant, life-threatening reaction. The important point to note is that it occurs very quickly, within usually 30 minutes to an hour, hour and a half after you start the rituximab. And it's always commonest in the first exposure because as B cells die, they release cytokines, and it feels like the patient's got the flu, right? So we all use pre-medication with diphenhydramine, acetaminophen, and methylprednisolone, but people do breakthrough. So it's very important to separate a standard infusion reaction, SIR, from a true anaphylaxis. The majority are fortunately going to get standard reactions, and the important point here is that you can stop temporarily and then restart the infusion after an hour, hour and a half, after you re-medicate these patients, okay? These are fever, chills, dyspnea, nausea, vomiting, and this is not sort of, these are non-specific. A little bit of itching may be there as well. But if you get urticaria or a repetitive cough or the patient's wheezing and complaining of throat tightness, and especially if shock, this is because of mast cell activation. And remember, rituximab has a murine, a mouse component, which patients may be allergic to, and that is a true allergy. So these patients should not get rituximab, should stop. You may need to give epinephrine, volume or oxygen, steroids and antihistaminics, but do not give this patient rituximab again. And luckily, we have alternative B-cell therapies that we can move these patients into if you think that these patients are doing very well on a B-cell therapy. But generally, we do not refer these patients for desensitization because it's complicated and the risk of these reactions do not go away completely. PML, feared and fatal complication of immunosuppression. So on top, this is the data on rheumatoid arthritis. So out of 350 exposed patients, only 9 experienced this complication. At the bottom is when rituximab was approved in approximately 2010. Between 2011 and 2015, there were about 50,000 patients, and there were 2 confirmed cases. So it does exist. It is not common. Patients need to be told that this is a risk, but is extremely rare. And unfortunately, or fortunately, we do have, we do explain to the patients that, you have a very serious disease. It's best treated with rituximab, but there's a small chance of this fatal illness. And then we come to something that's not universally recognized, but it's very important to recognize because B cell depleting agents are the highest risk of causing Hep B reactivation. Chemotherapy as well, but it's much less, it's moderate, and moderate dose corticosteroids can do this as well. High dose corticosteroids can cause B cell reactivation. When you combine the two in a patient with Anca, this patient is at extremely high risk of B cell reactivation. So what do? You screen all patients with your Hep B antigen, the anti-core, and the anti-Hep B surface antibody. And then if you're antigen positive, you immediately have to go into prophylaxis. And usually we do not use lemivudine, but you can use TAF, tenofovir alafenamide, or entecavir, which are both associated with very low levels of resistance. You try to start them at least 2 to 3 weeks prior to immunosuppression. And then if you're using rituximab, you may have to go for 1 to 2 years after because the B cell depletion obviously can last for a very long time. So here's the approach. So if you're antigen positive, go straight to prophylaxis. If you're negative, you look at your core positive, which is prior infection. And most times we look at the Hep B DNA. And the idea is if your Hep B DNA is positive, then obviously you'll get the antiviral therapy. But if you're negative, you need to monitor them very closely unless you prefer to be more sort of cautious and give all such patients therapy. But many of them will not reactivate if you're Hep core positive, antibody positive with the DNA negative. And you can watch them for reactivation with a viral load and LFTs. So that's what we typically do if you choose not to give prophylaxis in patients who are Hep B core positive with a negative DNA at the outset. With PCP or PCJ prophylaxis, so all patients are at risk because they qualify under this more than 6% risk category, which is more than 20 milligrams of prednisone plus another agent. So if you have this combination in any glomerular disease, please use your prophylaxis. And the drug of choice here is trimethoprim sulfur for reasons that was outlined previously. You can also use dapsone, and in people who are allergic or intolerant, atovaquone. So other B cell strategies. And why is this important? Because you give rituximab, it depletes B cells, but there's reconstitution. That's one aspect. And about 10% of patients may, with recurrent doses, have what's called anti-drug antibodies, right? For the most part, they don't cause a problem with depletion. But if you're not going into the 0 cells after getting rituximab, this may be an issue. So there are labs that actually measure rituximab levels. If you find that you're positive, your level's actually going down very quickly, this may be a real problem in managing patients. But it's easier to get a biomarker that basically reflects your level of depletion. So if you're not going down to 0 with rituximab, there's a good chance that you have anti-drug antibodies. Or if your drug is going down to 0, remember Dr. Fox said there are cells that do not have the CD20 receptor, and these are the long-lived plasma cells and the memory cells. So these may cause ongoing production of Anca and basically present as rituximab resistance. So you may have to do a completely different strategy by moving over to a cyclophosphamide-like regimen in these patients. The other point is that rituximab is not uniformly effective compared to the newer antibodies. So the so-called type 2 antibody is called obinutuzumab, and it has a direct cell death. It doesn't need complement to cause cell death. So it's a much more effective anti-B cell drug. And it's not been used in large trials, of course, but we use it quite routinely here at Columbia in patients who are either allergic or who have failed rituximab and their B cells are not going down to zero. And you can see, at least in small case series, that it does tend to be effective in patients who are allergic. You don't get a allergy. It's fully humanized compared to the chimeric nature of rituximab. So obinutuzumab is our go-to CD20 therapy in such patients. And the other drug that has also been used is ofatumumab. And again, this is humanized. And this is a regimen that was used in 8 patients with success. But this is again from England, and they used it in combination with cyclophosphamide. But the idea here is that if your CD20 therapy is working and you'd like to continue, there are 2 antibodies that you may draw upon in case the patient's allergic or if they start failing to respond to the CD20 therapy. Then lastly, we'll talk about B cell survival factors. So just like in lupus, if you have any autoimmune disease, you need B cell survival factors for the lymphocytes to maintain their activity against the antigen and produce antibodies. And also the plasma cells need these survival factors. So, and these are BAF and our APRIL and TASI. These are names of these survival factors. And there are receptors on all these cells that once they ligate, it produces a survival and ongoing production of antibodies. So if you block these factors, you may have an adjunctive therapy on top of depletion of B cells so that the production of these memory cells and plasmablasts and plasma cells are reduced by interrupting this pathway. So this has been studied in 1 clinical trial, just like in lupus. You add to azathioprine and glucocorticoids IV belimumab, and you look at the probability of relapse. These are patients who are in remission, and you go and see if these reduces the chance of relapse. But unfortunately, there was a significant 20% chance of relapse despite using this therapy. There's another trial called COMBIVANCE that's ongoing, and the results of this will hopefully be out in a year and a half. Then finally, we come to CAR T. So any B cell therapies is you cannot complete a talk unless you talk about CAR T therapy. And just to remind you, take the patient's own cells, the T cells, and you plug in an anti-CD19 CAR, and then you give it back to the patient so that anytime the T cell encounters a B cell carrying the CD19 receptor, it'll basically knock it out. So during the course of these cells being active in the circulation, you're going to take away the entire sort of a B cell population. And the idea is that we want to then maintain them on a immunosuppression-free protocol, and that has been quite successful in lupus. But what about oncovasculitis? So there's a preclinical model in this, and they looked at CD19 CAR T cells, and you can see at 8 weeks after infusing CAR T, there were no cells in blue in the spleen, bone marrow, lymph nodes, or in the peripheral blood. So complete depletion. Clinically, these mice had no crescents and no necrosis. So pretty powerful. When you look at the biomarkers, so albumin-creatinine ratio was lower. NGAL, which is a kidney injury molecule, was low. And your Anca titers also came down nicely in the blue group. There are 2 trials in China in refractory oncovasculitis. And there's one that is being considered in the US. It's not yet hit clinicaltrials.gov, but there's a strong chance it will. And this is going to look at a whole host of autoimmune diseases, including lupus. So to conclude, the B cell is critical in oncovasculitis. It's critical in the pathogenesis. It's the go-to or the most favored method of treatment in remission. And it's an effective alternative to cyclophosphamide, but please remember, adverse events are similar. It's effective in maintenance, and it's superior to antimetabolites. And again, adverse events are similar. We do not know what the optimal duration is, and we have to look at our patients carefully to see who's at a higher risk of relapse. And if you stop these maintenance drugs, we have to take a very, very cautious approach and watch them very carefully for for relapse. And we talked about future strategies, B-cell survival factors, and CAR T-cell therapy. So thank you very much. It's time for a break. We'll take a short break, 10 minutes, and then we'll come right back. Thank you.
As you heard earlier, there often is some C3 staining on the biopsies of ANCA-associated disease. But there's also a clear signal that ANCA autoantibodies activate neutrophils that in turn stimulate the alternative complement pathway to overactivate. And once that alternative pathway is activated, it's self-sustaining. So the alternative complement pathway is clearly involved in the pathogenesis of ANCA-associated glomerulonephritis. The group from Chapel Hill showed this beautifully in animal models. If you give a rodent anti-MPO antibodies, you'll induce the ANCA-associated glomerulonephritis, which you see in the top panel, with a necrotizing and crescentic glomerulonephritis with a heavy infiltrate of neutrophils and macrophages. If you deplete complement, which you're seeing on the bottom panel, panels E through H, if you deplete complement and give those anti-MPO antibodies, you essentially protect against the development of that ANCA-associated glomerulonephritis pattern on histology. Now, in terms of localizing which part of the complement pathway is involved, I mentioned earlier, and you also heard from Dr. Falk, that we're looking at the alternative complement pathway. How do we know that? Again, it's from beautiful experiments done by their group, which shows that if you knock out factor B, which is a key protein of the alternative complement pathway, and then you give the anti-MPO antibodies, you can protect against the albuminuria, the leukocyturia, the hematuria, the crescentic and necrotic glomeruli on light microscopy. Conversely, if you knock out C4, which is a protein that's involved in the classical and lectin pathways, you do not get that protection. So these knockout models clearly show that the alternative pathway is the key complement pathway involved in the pathogenesis of ANCA-associated glomerulonephritis. And if you knock out the classical and lectin pathways, the animals look no different than the wild-type animals. So we're really focusing on the alternative pathway as being involved in pathogenesis and in turn blocking those proteins if we're going to try to modulate the disease course. Now, we classically think of ANCA as a normal complementemic glomerulonephritis. However, there are patients who present with low levels of C3, and epidemiologically, those patients who present with low levels of C3 have done much worse. So on the left side of this, you're seeing renal survival. So low levels of complement are associated with far worse outcomes in terms of renal survival. And on the right side of this, you're seeing overall patient survival. Low levels of complement are also associated with overall decreased survival and higher mortality rates. So very clearly suggesting that more complement activation is associated with a more aggressive disease, worse kidney, and overall survival outcomes. Now, avacopan, which is a C5a receptor inhibitor, is the first complement drug that's made it to market for use in ANCA-associated vasculitis. And it's interesting to see how the drug was developed through early phase trials and then to the pivotal trial. So there were two phase 2 trials that were done. The first is the CLEAR study. This is the more definitive and important study in terms of how the drug moved through development and how it's intended to be used. So in the CLEAR study, there were 3 groups, each with about 20 patients. One group, all these groups got classic induction therapy with either cyclophosphamide or rituximab. One group got traditional prednisone treatment. One group got avacopan with low dose of prednisone, and one group got avacopan with no prednisone. And what you see very clearly in this study is that the group that got avacopan, whether they got it with a little bit of prednisone or with no prednisone, did as well or better than the prednisone group in terms of efficacy outcomes, but also did significantly better in quality of life. That was matched by a study called the CLASSIC study. The CLEAR study was done primarily in Europe. The CLASSIC study was an American study. The CLASSIC study similarly designed in that everybody gets induction therapy with rituximab or cyclophosphamide, but is either getting avacopan at a low dose or avacopan at a high dose on top of prednisone. So this is not a steroid-sparing study, but again shows that avacopan is associated with significant improvements in BVAS scores and essentially non-inferior to prednisone. Fortunately, the CLEAR study, which I showed you earlier, which had that steroid-sparing component, is the one that held more weight as they moved on to the phase 3 study, which is the ADVOCATE trial. And this is a pure steroid-sparing type of study where everybody gets induction therapy. It was up to the treating physician whether they wanted to use Cytoxan or rituximab. But then the groups were either randomized to avacopan, 30 milligrams twice daily, or prednisone with placebo avacopan given. So we're really comparing here avacopan on top of induction immunosuppression versus prednisone on top of induction immunosuppression. And here are the outcomes. So at 26 weeks, there is essentially no significant difference between avacopan and prednisone, and this was powered to be a non-inferior trial because, as you'll see, avacopan is expected to have less side effects given that it's a targeted drug at the level of C5a receptor, and of course, we're well aware of all the side effects of prednisone. But when you go out to 52 weeks, what you see is that avacopan is actually showing superiority to prednisone with higher rates of sustained remission at 1 year compared to prednisone. Now, in part, this is because patients are being weaned off prednisone and maintained on avacopan. But again, that's an important signal because we don't like to treat with prednisone for a year where there clearly appears to be a safety signal that you can continue avacopan out to 1 year. And that was shown in the adverse events where there's lower rates of adverse events with avacopan compared to placebo. Now, since Advocate was published, there have been a number of trials that have, a number of publications that have come out doing subgroup analysis of the Advocate trial, trying to better tease out which patients can we still be able to treat with avacopan. And one of the earliest questions was, what about the patients with the most severe renal failure? Can they be given avacopan, or do those patients need prednisone? Well, this is a very small subgroup of the Advocate participants. So if you look, it's only about 15% of the patients in Advocate had GFRs less than 20 when they enrolled. So that very severe disease was not well represented in Advocate. But in that group that did, you have 27 who were randomized to avacopan, 23 that were randomized to prednisone. You can see that avacopan does appear to work clearly as well, and there's a signal that it's actually working better than prednisone in that small subgroup. So the conclusions of this subgroup analysis were that low renal function should not preclude you from using Advocate dosing of avacopan. What about the patients who were treated with rituximab, which traditionally is sort of viewed as maybe not as an intensive a therapy as cyclophosphamide? I think Dr. Radhakrishnan's talk sort of poured some water over that theory, but this is another subgroup analysis led by Dr. Geetha, who you heard from earlier, just looking at the Advocate participants who received rituximab. And the important part about this is that there was no maintenance therapy given. So in the Advocate study, if you got rituximab as your induction therapy, you did not get maintenance therapy at 6 months. The cyclophosphamide induction group went to azathioprine induction therapy. So here, this is rituximab as induction with no maintenance. And you can see that staying on avacopan for a year clearly outperforms prednisone at all patients, and then even they do the subgroup analysis in patients with 30. So again, that I might have the kind of patients where I could potentially forego maintenance. That has to be, in my opinion, a select patient. Symptoms and can be really closely followed. You have a signal that you're able to do that using rituximab with avacopan. What about the group with alveolar hemorrhage? An even smaller subgroup in Advocate. But again, they are publishing all these subgroups now. 8 patients in Advocate who had alveolar hemorrhage who were treated with avacopan. There's no comparison group here. They're just showing the 8 patients who were treated with Avacopan, all of whom did very well from a pulmonary standpoint. And so they're saying here that if you have the presence of alveolar hemorrhage, it should not necessarily preclude you from considering Avacopan in the treatment course. I think one of the most important parts of using Avacopan, if you're going to be using it in lieu of steroids, is looking at the quality of life data. And that's where this subgroup analysis and more detailed analysis of quality of life data, which was published last year, is really important. You can see just how much better Avacopan is performing compared to prednisone in these quality of life measurements. This is a physical component summary score. This is a mental component summary score. And a lot of this is common sense. If you treat patients with prednisone, you know it can be a potentially toxic therapy for a significant numbers of our patients. And so to me, the allure of using complement targeted therapy is essentially the allure of being able to use a steroid sparing regimen. The Pexaval study, which was discussed earlier, really showed us that we don't need to use such high doses of steroids in our patients, and we can get away with much lower doses of steroids. But what the Advocate trial is suggesting is that we potentially have a route to go to a complete steroid-sparing regimen in total, where you would just give 3 days of IV pulse solumedrol and immediately shift to complement blockade without any long-term corticosteroid use. Now, the data that I think is the most crucial to come out after Advocate beyond these subgroup analysis is what has been called the real-world experience with the Avacopan and ANCA-associated vasculitis. So this is a group of nephrologists who pooled their data in terms of how they've been using Avacopan since the drug was FDA approved after the Advocate study. So it's a multi-center retrospective cohort analysis. This was first presented at ASN Renal Week this year, and there's a manuscript that's under review at KI Reports, which hopefully will be published soon. And this is looking at 92 patients who were prescribed Avacopan in the real world for newly diagnosed or relapsing ANCA-associated vasculitis. You can see there's a nice mixture of both granulomatous polyangiitis and microscopic polyangiitis. The vast majority have renal involvement, about 80%, with significant kidney disease, including 9 of them on dialysis at entry, and 23% with entry GFRs below 15 mLs per minute, a number of whom received plasmapheresis. And when we look at how they were induced, again, this is really representative of the way ANCA is being treated at vasculitis centers. So you're seeing the induction regimens often are combining cyclophosphamide with rituximab or using rituximab alone, which are really the 2 ways that we think about treating it. And many of these patients had good outcomes. So at 26 weeks, 90% remission. At 52 weeks, 84% remission. But importantly, 20% of the patients stopped Avacopan due to adverse events, including 4% with transaminitis. So you're really getting a nice view of how the drug's been used out in real-world practices. I think this is a really important piece of data that's coming out of these real-world experiences. Patients who were treated with Avacopan earlier, who are in the blue bar, appear to be doing slightly better at week 12, and then as you go out further and further, doing better and better out to week 52, compared to patients who had a delay in starting Avacopan. And that's important because the longer you're delaying in the start of Avacopan, the more you're exposing these patients to corticosteroids. And in fact, that was shown really nicely. And again, the groups that's starting earlier is getting less and less corticosteroid exposure than the group that had a delay. So I really do think if you're thinking about using Avacopan, this is something that you should table. This is something you should actually say, if I'm thinking about doing it, I need to make the decision now as quickly as possible to get my patient on this and reduce the amount of corticosteroid exposure that we're going to put this patient through. So when I think about patients to consider for Avacopan, I think there's some obvious candidates. And the most obvious candidates for me are those patients who have a high risk for steroid toxicity. That would be anybody with diabetes, anybody with obesity, patients with osteoporosis. Of course, we know that there is a large subgroup of patients who are 65, 70 years of age or older who have ANCA vasculitis. It's actually responsible for about 1/3 of all AKI biopsies will be post-immune GN. So those older patients with osteoporosis, again, would be someone I would think about using Avacopan and minimizing their steroid exposure. And then patients who have a history of frequent infections. Also, obvious candidates are prior use of corticosteroids, because we know that steroid toxicity is very heavily associated with cumulative steroid exposure. So any relapsing patient, I'm going to again think about using avacopan over corticosteroids. Patients that to me are not yet obvious candidates. If you have mild MPO-mediated disease, can I use avacopan to allow for no maintenance therapy? I think that's a very intriguing part of using avacopan. There's data from the Advocate study. I'm very heavily considering this, but it's not as obvious as the previous candidates that I talked about. But if I have someone with very mild disease and I can get that MPO to go negative within 6 months and they're on avacopan, I may think about not using maintenance therapy. Severe or resistant disease. Does avacopan provide a better chance at remission than corticosteroids? Some of the subgroup analysis from the Advocate suggests that. However, if I see someone with a very heavy crescentic burden, more than 50% of their glomeruli have crescents, I'm still tending to go the corticosteroid route over avacopan. Finally, access to avacopan. Can I get this patient on therapy quickly? Fortunately, I think this is improving, but it's something that continues to evolve. If you're going to think about using avacopan, you have to make sure you can get that patient on therapy quickly, because there does appear to be a benefit in starting it earlier rather than later. Patients I'm not quite ready to consider for avacopan. Anybody with AKI requiring renal replacement therapy. The data on this is still very, very low. There's a few patients in that real-world study, but we need to see much more. Patients with diffuse alveolar hemorrhage. You saw the Advocate study. There were only 8 patients. I definitely want to see more. Coexistent anti-GBM disease. I think we're still leaning on corticosteroids in that situation, and I already mentioned the heavy crescentic patient. I'm still leaning towards corticosteroids over complement inhibition. And all the data that I've shown you and all the talking that I've talked to you about is about avacopan, but there are other agents that are in development, other agents that are on the horizon, one of which, IFX-1, is a monoclonal antibody that targets C5a. It was used very similarly to the way avacopan was used in its trials as a steroid-sparing agent. The data has not been published in the literature, but if you go to clinicaltrials.gov, you can see some of the early data on using this. And like avacopan, it appears to be non-inferior to corticosteroids. So this may be another anti-complement drug that we may be thinking about using in the future. And then complement inhibitors are a huge field right now in glomerular diseases. They're being used in diseases other than Anca. So we're seeing a bunch of complement inhibitors being developed that target along the alternative pathway, including factor B inhibitors, C3 inhibitors, factor D inhibitors, and other C5 targeting therapies. So it's not out of the question that some of these or many of these that target the alternative pathway will eventually be used in the treatment of ANCA-associated disease. But right now we only have that one that's FDA approved to use, but this is on the horizon. So to conclude, the alternative complement pathway has a clearly defined role in ANCA-associated vasculitis. Complement targeting therapies offer the potential of precision medicine with disease-targeting therapy and reducing exposure to a potentially toxic medicine in corticosteroids. Avacopan is the only available complement drug for ANCA-associated vasculitis now, but I think that might change in the future with the number of complement targeting drugs in development. And the trial and real-world data on avacopan suggests some ideal candidates for therapy in terms of being able to avoid steroid toxicity, avoid re-exposure to corticosteroids, and a clear benefit to earlier start of avacopan versus the delayed start. So I will stop there, and we will move on to
approach to this disease and talk about maybe some of the complications that can happen with therapy. So I'm going to play a little bit of the devil's advocate, actually. So hopefully this presentation will help you to make informed risks and benefit decisions when you're discussing with your patients. And in some of the medications, I'll also discuss the mechanisms of the medication itself, since the adverse events can actually be related to the mechanism of the drug. So I have no relevant financial disclosures. So by the end of this talk, you should be able to identify the complications of therapy that are used in treating ANCA-associated vasculitis and consider approaches to decrease the complications of these therapies. So just our overview. So we're going to have two sort of approaches to this discussion. So the first approach, we're going to identify the complications of ANCA vasculitis therapy. We're going to go through different medications as well, sort of medication by medication. And then kind of coming back to the complications of ANCA vasculitis therapy, we're going to kind of take a more proactive approach on how to manage and maybe prevent some of these complications. So I'd like to talk then about vaccinations. We'll talk about prophylaxis, fertility preservation, contraceptive use, and screening for glucocorticoid-induced osteoporosis. So starting off with identifying complications, I actually want to start off with glucocorticoids or so these are obviously very, very widely used in medicine overall. And in ANCA vasculitis, their medications take a few months to work and to have a clinical effect. Steroids are the prototype immunosuppressant. They are not specific, but warn all immune system cells to shut down inflammation whenever we need a fast response. Most of the effects of glucocorticoids are through genomic transcription changes, so it still takes about 24 to 48 hours. And then there are some rapid effects at very high doses that go through some of the non-genomic mechanisms. We use this in nearly all of our rheumatic diseases. Because of these early immunomodulatory effects, we have bridging dosing that we use, and it can help with, obviously, organ manifestations. So the mechanism of steroids is they diffuse through the cellular membrane inside the cytoplasm, and you can see that they bind to these steroid receptor called steroid glucocorticoid receptor complex, which you can sort of see over here. At these particular areas, so next this complex goes into the nucleus, binds to the DNA, at particular areas called glucocorticoid receptor elements, or GRE. And what they end up doing are two things. One, they turn on the anti-inflammatory genes, and this process is called transactivation, or they turn off pro-inflammatory genes, and this process is called transrepression. So eventually, both of these lead to the synthesis of anti-inflammatory proteins. And this is the nonspecific anti-inflammatory response of steroids. It can affect thousands of genes directly or indirectly. At very high pulse IV steroid ranges, you can have faster non-genomic effects that may not necessarily involve the cytoplasm steroid receptors, and instead sort of mediates through other modalities. So these modalities include the calcium-sodium cycling across the plasma and mitochondrial cell membrane. It has an effect on heat shock proteins. They turn on and off kinases in the cytoplasm. And this leads to other effects of steroids, such as the vascular effects like hypertension or neurotransmission, leading to that feeling of euphoria or mood changes, the endocrine effects or the smooth muscle effects or the skeletal muscle side adverse effects. So the list of glucocorticoid side effects seems to be almost endless, as many of you might know. So CNS-wise, it can cause depression, psychosis, insomnia, hypervigilance, euphoria, hunger, ocular effects, cataracts, glaucoma, cardiovascular, such as hypertension, tachycardia, atherogenesis with long-term use, bone, osteoporosis, AV necrosis of the joints, skin, including topical glucocorticoids, can cause skin atrophy, acne, endocrine effects, hyperglycemia, hyperlipidemia, muscle effects with atrophy, GI effects with peptic ulcer, and obviously the immune effects with infections. So in the treatment of autoimmune disease, there's been a movement to reduce all of these effects of steroids, especially the toxic effects. A recent study by Walsh, published in 2020 in NEJM, demonstrated a reduced dose glucocorticoid regimen provided a similar benefit to a standard dose regimen for the composite outcome of ESRD or death. It was also associated with the decreased risk of infection And of note, both the standard dose regimen and the reduced dose regimen started with pulse dose steroids, methylprednisolone, three daily pulses for a maximum total dose of 3 grams. However, the standard dose began at 60 milligrams daily with a taper to 15 milligrams by the end of 3 months, then 5 milligrams a day by 6 months. While the reduced dose regimen began at 30 milligrams, tapered down to 7.5 milligrams a day by 3 months, and then 5 milligrams a day by 6 months. So this has led the ACR, which is the American College of Rheumatology, to conditionally recommend a reduced dose steroid regimen for the induction of patients with active severe ANCA vasculitis. And here you can see the similar benefit of reduced dose regimen to standard dose regimen for the composite outcome of ESRD or death, as well as ANCA vasculitis remission. You can see it was also associated with a decreased risk of infection. So let's move on to anti-B cell therapy, focusing on rituximab. We had a wonderful lecture earlier today regarding B cell therapy. So just as a brief review, so plasma cells are the ones that eventually create your immunoglobulins. However, if you give a patient repeat cycles of rituximab infusion, over years and years, eventually, you would affect these sort of precursor B cells, leading to a decrease in plasma cells and eventually to immunoglobulin counts. So the long-term consequence of repeat cycles of rituximab include hypogammaglobulinemia, which occurs in most cases eventually in patients who have repeat cycles of rituximab. And this can lead to the potential for an increased risk for infections. Higher doses of IVIG or immunoglobulin replacement therapy have been associated with a reduced risk of severe infections in these patients. Also with B cell therapy, one of the adverse effects to evaluate for is vaccinations and how these patients respond to vaccines. So there can be a decreased vaccine efficacy, and timing of the vaccines are important in terms of dosing rituximab. And we'll talk a little bit about this later in the lecture. And with B cell therapy, one of the most feared complications is the risk of reactivation of JC virus, which can lead to progressive multifocal leukoencephalopathy or PML, which itself can have a significant mortality of almost 50%. It's very, very rare, fortunately. Most of the studies of PML have been done in oncology when patients are on multiple chemotherapy agents. But if PML were to happen, it's a fatal opportunistic demyelinating disease of the CNS, which results with infections of oligodendrocytes by JC virus. And reactivation can occur of latent JC virus during periods of immunosuppression. The data has been, and the literature has been primarily in patients with HIV, cancer, organ transplant, as well as chronic inflammatory rheumatic disease. Just to sort of briefly go over PML, there are 3 significant clinical presentations of the disease. Patients would present with impaired vision, so they might describe defects in their vision. They may have motor weakness as well, hemiparesis or hemiplegia, as well as changes in mentation, including personality changes, difficulty with memory, emotional lability, or frank dementia. This is a cross-section on the right of the frontal lobe of the brain of a PML patient, which you can see here in A. And you can see sort of this apparent myelin loss around here as a result of the JC virus of oligodendrocytes that's made detectable by a blue staining. The demyelinated areas are pretty visibly distinguished as the white plaque areas. Whoops. Compared to sort of the blue stained areas. And over here you can see in the H&E staining of the brain sections of a PML patient, which reveal the infected oligodendrocytes that It's detected by this round, dark staining of these eosinophilic inclusion bodies, which you can see over here. And then the arrow here points to a infected astrocyte. Fortunately, there is no medication for effective treatment of PML, but the prevalence or the incidence is quite low. So the estimated incidence of PML was 0.2 per 100,000 persons for rheumatic disease treated with rituximab or infliximab. So let's move on to what we call antimetabolites, which are medications that interfere with the cell cycle. So methotrexate is a very old medication. It was first used in the 1950s to treat malignancy, primarily with high doses via the IV route for oncological applications. And then in the 1960s, that's when we started getting the first reports of its use in rheumatic disease, eventually becoming the gold standard for rheumatoid arthritis therapy. We use it for other rheumatic diseases as well, such as the maintenance of remission in vasculitis. And typically, it's used at low doses, so it can be used either weekly or oral or intramuscularly. For rheumatic diseases, the starting dose is typically 15 milligrams and can be titrated up to 25 milligrams every week. Usually the medication is taken orally, but it can also be taken subcutaneously, which has a kind of an improved bioavailability. It is excreted by the kidneys, and thus it has to be adjusted in those with CKD or reduced glomerular filtration rate. The other part with methotrexate is that it can accumulate in third-spaced fluid, so it has to be used with caution in patients with ascites or pleural effusions. And the primary way that methotrexate works is that it's a folate analog. So as a folate analog, it's taken up by many cells in the body in the same way that the cell will take up folic acid. So once methotrexate is uptaken, it's polyglutamated, so it must stay within the cell. It cannot leave the cell. And it inhibits the cells in two ways. It inhibits via the DHFR enzyme, which is responsible for the synthesis of methionine, the ultimate creation of nucleotides for cell synthesis. So that's important for cell proliferation. And then the second mechanism is that it metabolizes, is the metabolism of ICAR enzymes, which eventually lead to the increase in adenosine, which an adenosine has this anti-inflammatory effect. So since we're interested in affecting cellular proliferation with methotrexate, you can also have an effect on cells that proliferate the most. So that includes the bone marrow cells. Thus, we can see cytopenias, bone marrow suppression with methotrexate. Also, meanwhile, rapidly proliferating are your skin cells or your mucosal cells, which can be affected with methotrexate. So you can get methotrexate-induced alopecia, stomatitis. And this is the reason why we dose methotrexate with folic acid, to decrease the adverse effects without really significantly affecting those anti-proliferative effects. So high doses of leucovorin can sort of mitigate some of these effects of methotrexate toxicity, especially those, those with maybe kidney dysfunction. And then through the mechanism of adenosine on liver cells, methotrexate can have a profibrotic effect, particularly when combined with heavy alcohol consumption. So that's another reason why methotrexate can be dangerous in patients with cirrhosis. Vaccine for when the next rituximab is due, and then hold the rituximab for at least 2 weeks after. For other immunosuppressants, we continue the immunosuppressive medications. This is sort of some data that shows antibody titers for patients who were vaccinated and so on. So prednisone, especially at 20 milligrams or higher, we tend to try to defer maybe some of the non-live attenuated vaccines until they're possibly on a lower dose, because there's data to suggest that the higher doses of prednisone can have an effect on vaccine efficacy. And in the past, live vaccines were completely contraindicated because there was very little data. But now that we have much more data, because the live vaccines contain sort of a small amount of weakened live virus, not necessarily all immunosuppressed can be ready to obtain the live vaccine, but according to the ACR guidelines, they are conditionally deferred but not contraindicated. So if you do have to give a live vaccine to your patients, so that includes MMR, rotavirus to the pediatric population, smallpox, hopefully we don't use as much, chickenpox or yellow fever vaccine for those who are traveling. These are sort of the recommendations. So ideally, we would like to maybe hold the some of the immunosuppressants 4 weeks prior to the live vaccine virus administration and 4 weeks after. And then when it comes to rituximab or cyclophosphamide you may hold for 1 dosing interval and a month later, and rituximab 6 months and 4 weeks. So not completely contraindicated, but there is a dosing regimen as per the ACR. Running out of time, so I'll kind of go through quickly. So patients who, this is for ANCA-associated vasculitis mothers who are on rituximab during pregnancy. So just to be aware, and I tell this to my patients, that if they're receiving rituximab, rotavirus, which is a live vaccine that's given to newborn patients, I recommend deferring it until 6 months of life. So even according to the ACR guidelines, they've now published to give the rotavirus vaccine 6 months later. So I talked to the mother's child's pediatrician. And just kind of quickly going through prophylaxis for PJP. So it's considered for patients who are receiving moderate dose glucocorticoids, 20 milligrams a day or higher. There's a conditional recommendation to use it for cyclophosphamide or rituximab. And we don't have any guidelines regarding CMV prophylaxis, PPI for GI prophylaxis, or fluconazole prophylaxis. Fertility preservation, so on average, about 40% of patients who undergo chemotherapy, specifically with cyclophosphamide, can develop ovarian failure. And it really depends on the type of therapy, the cumulative dose, like how often or how much they've gotten it over their years, the age of the woman before treatment. Menses can resume in 23% of these patients, but there's a high risk for ovarian failure. Megan Klaus conducted a meta-analysis demonstrating that the co-treatment of GnRH analog during therapy with cyclophosphamide increases the odds of a woman maintaining her ovarian function. And this is something that we use actually quite often if we have patients who undergo cyclophosphamide. And something to also bring up with your patients is oocyte sperm or sperm cryopreservation. So talking to them about how to maintain their fertility. And just as a reminder, to use contraceptives with methotrexate, mycophenolate mofetil, cyclophosphamide. For females who are planning to become pregnant, consider switching to azathioprine. And I think our last slide, so osteoporosis screening. So those who are on chronic steroids, you do want to risk stratify these patients who are maybe at high risk, especially adults greater than 40. You want to look at their FRAX score. Their high category risk is if they have had a prior fracture, if they have a low bone mineral density, high FRAX score, or high glucocorticoid use. Thank you very much for your time. And I'll end it here.
Cells per high-powered field. Urine albumin to creatinine ratio was about 900 milligrams. He did have a positive anti-SCL70 antibody, quite a high titer ANA, and a low positive double-stranded DNA as well. Complements were normal. Rheumatoid factor was normal. Myositis panel was normal. Hemolysis labs, including haptoglobin, LDH, and reticulocyte count were normal. And hepatitis B and C serologies and HIV was negative. So based on this, it was immediately apparent that he would need a kidney biopsy, and he indeed had one. And I'll ask my colleague, Dr. Kudose, to take us through the biopsy. And Satoru, if you'd like, I can drive the slides.
Okay, sounds good to me. So the next slide, please. So the biopsy contained 42 glomeruli, most of which looked normal, like shown here on a PIS stain section. But 22 glomeruli demonstrated crescents, 10 of which were cellular, as shown here around 9 o'clock, with PIS negative fibrinoid necrosis in the center. Next slide. So silver stain also highlights the fibrinoid necrosis as well as the breaks in the capillary loops, as you can see here. So you can see the discontinuity in the GBM. Next slide. And the fibrinoid necrosis is also highlighted by trichrome stain. So it's always red in trichrome stain. Next slide. So 13 glomeruli showed active crescents, but 9 showed fibrous crescents. So these are inactive crescent. And you can see the fibrous area with a much reduced cellularity compared to the cellular crescent here. Next slide. In addition to the glomerular finding, the biopsy showed mild to moderate IFTA. So the arrows are pointing to atrophic tubules with a small profile and also thickened and wrinkled TBMs, as you can see here. Next slide. And the vessels did not show any vasculitis, but instead just showed intimal fibrosis. These are just chronic changes from hypertension and aging. And next slide, please. So immunofluorescence was essentially entirely negative, except for anti-fibrin. So the fibrin is staining in some of the glomeruli, and this corresponds to the area of fibrinoid necrosis that we saw before. Next slide. Electron microscopy was helpful in that it did not show any electron dense deposits, so it confirms the immunofluorescence being negative. And podocytes showed 60% effacement. And next slide. So this case was diagnosed as a falci-immune focal segmental necrotizing and crescentic GN. So this is a typical finding that we see with Anca vasculitis. And the findings are both active and chronic. So among 42 glomeruli, 13 showed active crescents and 9 showed inactive crescents. Importantly, there was no evidence of immune complex mediated GN, such as lupus nephritis, and there was no evidence of TMA, which is a finding that you see with scleroderma renal crisis. And this is, you can see it here that sometimes we can get the results before the serology. So anti-MPO antibody resulted one day after the biopsy result, and it was positive. So this is classic for MPO Anca vasculitis involving the kidney. And back to you, Pietro. Oh, yeah, actually, one more thing. So etiology considerations for this particular finding. So it's important to make sure that you're not dealing with medication-induced Anca vasculitis. So most of the time it's hydralazine or anti-TNF-alpha inhibitor and other medications as well. With these medication-induced Anca vasculitis, sometimes you do see a little bit of a feature of immune complex mediated GN, as shown by Dr. Santori-Eno a couple years ago. And another important things to exclude is endocarditis associated GN. They can look like Anca vasculitis, but in those cases, C3 is usually positive, although they don't have to be. And some cases of lupus nephritis can also look like this, but in those cases, you have typically positive immunofluorescence. So those are helpful features if you see it. So that's all. And now back to you, Pietro.
Thanks very much, Dominic. So clearly we now have a diagnosis and he began treatment. So at the time of the biopsy, he was actually hospitalized, and he underwent a pulse of methylprednisolone for 1 gram daily for 3 days, and then transitioned to prednisone at 30 milligrams a day. And he was also treated with rituximab, and the dose he was given was the 1 gram every fortnight. And so with that, initially, he apparently did well. His creatinine, you can see, peaked at 2.3, but then at 4 months came down to 1.34. His anti-MPO antibody level was still elevated, but much lower than initially. And at this point, he was put on mycophenolate mofetil for maintenance. This was added in part because of consideration of his scleroderma symptoms and the presence of lung disease, for which there is some evidence for mycophenolate. So mycophenolate is used, I think, much more often in ANCA vasculitis by our colleagues in rheumatology than by nephrology. And the reason is that there's evidence for it, particularly in milder forms of vasculitis, but in severe ANCA vasculitis, I think it's suboptimal. And it's suboptimal both for achieving remission, and that was shown in this series from the Netherlands. And in particular, if you look, this was a series that looked at patients who were already diagnosed with ANCA-associated vasculitis and were relapsing. They were on their first or second relapse. Now, most of these were PR3 positive, which of course relapses at a higher rate. But they compared patients treated with cyclophosphamide to those treated with mycophenolate. And it was a multi-center randomized controlled trial, and particularly if you look at the subgroup analysis by BVAS score, those with the highest BVAS score, the most severe disease, as you can see in the cyclophosphamide group compared to the mycophenolate group, as the BVAS score gets higher, the cyclophosphamide seems to be much better at achieving a remission at 6 months. So for severe organ-threatening disease, I think it's not as good. Mycophenolate is not as good as cyclophosphamide, certainly. For achieving remission and also for maintaining remission, and this you've seen before, this is from the IMPROVE trial, which shows that a slightly higher rate of relapses in the group treated with mycophenolate compared to the group treated with azathioprine. So what happened to this patient? By 6 months, his creatinine was already starting to go up again, and he was redosed rituximab for maintenance and maintained on mycophenolate as well. Actually, he came off of prednisone completely as mycophenolate was up titrated, and despite this, at 1 year, his creatinine had gone back up to 2.2. Anti-MPO was again 200, and urinalysis actually revealed ongoing proteinuria and hematuria. And this, at this point, he was actually referred to us at the Glomerular Center, and we saw him. So this was a year after his first biopsy, and despite appropriate therapy with rituximab, a taper of prednisone, and ongoing mycophenolate, he did have these signs of active urine sediment. And so at this point, we elected to repeat the kidney biopsy. There was always, in the setting of systemic sclerosis, a question to ensure that there was not a trigger of scleroderma renal crisis with thrombotic microangiopathy, particularly with the prednisone use, and again the unusual flaring despite rituximab. So at this point, a repeat kidney biopsy was performed. I'll ask Dr. Kadose to help us through that as well.
Okay, so the second biopsy showed much more chronic changes compared to the prior biopsy. So here we have an example of fibrous crescent with fibrous areas highlighted by the arrow here. But note that the glomeruli here look ischemic and shrunken, but they don't show any hypercellularity. Next slide, please. So again, here on low magnification, you can appreciate the increase in chronicity compared to the prior biopsy. So the area highlighted by oval is entirely atrophic. And even at this low magnification, you can appreciate glomeruli with fibrous crescent. You can see that on the right-hand side at the edge, and as well as increase in global sclerosis compared to the prior one. So we have 2 glomeruli in the center with global sclerosis. Next slide, please. But there was some evidence of activity still in the second biopsy. So you can see here pointed out by an arrow, an example of cellular crescent. Next slide, please. So in summary, so the second biopsy again showed post-immune focal segmental necrotizing and placentic GN, as well IF and EM showed a similar finding as before. But in terms of activity, of the 16 glomeruli, 2 showed active crescents, and there were 5 with fibrous crescent, so these are inactive ones, and 7 with global sclerosis. So compared to the prior biopsy, the glomeruli are showing much more chronicity, but still persistent activity. And also in the tubular interstitium, you have this increase in tubular interstitial scarring, so 40 to 50% in contrast to 30% from before. So overall, same disease, more chronic changes with persistent activity.
And without any thrombotic microangiopathy or any indication of other disease process.
Yeah, exactly.
Thank you. Thanks very much, Satoru. And thank you for the help with the patient. So here we have clearly delineated the problem. This is a patient who's gotten a lot of immunosuppression and still has active disease with worsening chronicity. So not only is the disease active now, but it seems like it has been active. So this is a case of refractory ANCA vasculitis. And refractory ANCA vasculitis has been described for about as long as we've had treatment. So in Tony Fauci's original New England Journal paper in 1979, of 17 patients with vasculitis, I believe all women, 16 of whom were treated with cyclophosphamide. 14% of those patients, and this was novel at the time, had complete and often dramatic remissions, but 3 of them died. And so just 14 out of the 16 had remissions, which means 2 of them did not. And so what is refractory disease? Depending on how you define it, as defined by EULAR, unchanged or increased disease activity in acute ANCA vasculitis after 4 weeks of treatment with standard therapy, or a lack of response, which they define as less than a 50% reduction in the BVAS after 6 weeks, or chronic persistent disease defined as presence of at least 1 major, 3 minor items in the disease severity score after 12 weeks of treatment. These are the types of definitions which are used a lot more by rheumatologists. I think myself as a nephrologist, I'm not as used to checking off BVAS scores or looking at major and minor items. At the end of the day, what you can see is, despite a few weeks of treatment and appropriate treatment, we have active disease. Clearly, this would qualify the patient that we're discussing. And how common is refractory vasculitis? So in this first paper, it was 2 out of 16, and in several other papers of including modern therapies, as you can see summarized, the rate is somewhere around 5%. So 5% of patients who treated appropriately will still have refractory disease. So this is rare, and we don't see a case even in my own practice. I don't see a case every year, but I do have a few cases of this. The problem is how to treat this. And we have 2 different sets of guidelines, one from KDIGO, one from EULAR. So KDIGO in 2021, the guidelines mentioned you can use an increase in glucocorticoids, add rituximab if cyclophosphamide has been used, or add cyclophosphamide if rituximab had been used, consider plasma exchange. EULAR says the same thing about cyclophosphamide and rituximab, switching between one and the other, kind of as we do in lupus with cyclophosphamide and MNF. EULAR also mentions other strategies, including adjunct IVIG, switching from pulsed IV to oral cyclophosphamide. And it makes the claim for patients with refractory disease, the best option may be consideration or referral to centers participating in clinical trials. I'll point out that's not as easy as it sounds, just because of the lack of clinical trials that are out there right now. So what other options do we have? I think there's, from the publication of these 2 guidelines, there's 2 other things worth thinking about. So first is avacopan. And avacopan, you've heard a lot about today, especially right now from Dr. Bombach, just within the past hour. And there's this case series that was described of patients with refractory disease, steroid resistance, 8 patients, who were all appropriately treated with rituximab. 5 of the 8 had renal involvement, and all of them were treated with avacopan and compassionate use because of their refractory disease. And this series was positive on the use of avacopan. All patients had a clinical remission after starting avacopan within 6 months. One patient flared after the medication was reduced, not stopped, but reduced, but all of them saw an improvement in GFR. And what you can see here are the BVAS scores, which are going down over time for the 8 patients. The required prednisone dosage is going down over time after the 8 patients. And you can see that their clinical course is summarized here, and in green is clinical remission. You can see that here's 6 months, they're all going into clinical remission. This is the patient who then has a flare of disease, but returns into remission after the dose is increased. So this is a small case series, only 8 patients, but these are particularly hard patients to treat, and so it's worth considering this as an option. It's another option which did not make it into either the EULAR or the KDIGO guidelines, but that's a drug called obinutuzumab. Now, you might have heard about obinutuzumab. It is FDA approved for B-cell malignancies. It is an anti-CD20 antibody like rituximab, but it is basically a more potent depleter of B cells. It depletes cells much more quickly than rituximab, much more deeply, including in non-circulating B cells, and for a much longer time. And its cytotoxicity is slightly different than rituximab. It's a fully humanized versus a chimeric antibody, so has, at least in practice, a lower risk of allergic reaction as well. And 100 times the antibody-dependent cellular cytotoxicity than that of rituximab. So obinutuzumab has been approved for hematologic malignancies that are refractory to rituximab. It's been studied with some positive preliminary data in lupus. And so it would be logical to think of it as a possibility if we have another disease that tends to respond to rituximab here, vasculitis, could we use obinutuzumab for refractory disease here? There is very little published yet, but there was this report. It was a case report of 3 patients published within the past 2 years and came out of the rheumatology and nephrology group at Penn, including one of our former fellows. All of these 3 patients had failed rituximab either due to allergy or non-response, and all responded clinically to obinutuzumab, and all were found to have B-cell suppression and actually seroconverted their Anca antibodies to negative as well. The question comes up, so what about clinical trials? So if you look, there's really very little out there right now. There's 2 randomized clinical trials of obinutuzumab versus rituximab that are actually recruiting, one in the United States, but just at 3 centers. The Mayo, MGH, and the Penn Vasculitis group are recruiting a randomized trial, and there's another one called OBVAS that's recruiting in the UK. But the idea that there's really nothing else out there right now as far as randomized controlled trials. So unless you have a patient who's close to one of these centers and qualifies, the idea of referring for clinical trials is always noble, but you have to know what's available, and right now there's very little available. So I'll tell you what we actually did with this patient. After the biopsy, we stopped his mycophenolate. We resumed a prednisone taper, and we did a rapid Pexivast taper with close attention to his blood pressure and hemolytic markers, in part because of the systemic sclerosis and caution about not wanting to trigger scleroderma renal crisis. And because he had failed rituximab, we treated him with cyclophosphamide. And so he received a course of cyclophosphamide intravenously, and we actually started him on avacopan additionally as assistive therapy. He initially did well. After 6 weeks, he had a disappearance of hematuria. Albuminuria decreased, actually, and his MPO was falling from 200 to 120 with an improvement in creatinine. It actually came down to a nadir of 1.8 from a peak of 2.5. Unfortunately, subsequently, at 1 year, labs went in the other direction. And he had been resumed by his rheumatologist on mycophenolate for maintenance. And at 1 year, he was found to have a return of hematuria, an increase in albuminuria, an increase in his MPO titer, and an increase in his creatinine. And so at this point, we did elect to, after discussing with him the risks and the substantial immunosuppression he'd already received with organ-threatening disease that was clearly progressing, we did elect to treat him with obinutuzumab, and he just received it recently. The dosing is similar to rituximab, 1 gram for 2 doses. And thus far, he tolerated very well. He has had, I confirmed, he has had full B-cell depletion. His ANCA titer and his albuminuria have slightly improved. I think it's too early to see a change in creatinine, but perhaps if you come back next year, I'll give you an update on them. So in summary, this is refractory ANCA vasculitis. It occurs in somewhere around 5% of cases, despite standard of care therapy. The morbidity is quite high if there's major organ involvement, and evidence-based treatment is really limited for this entity. Therapeutic options, you can intensify steroids if a patient can tolerate it, switch from rituximab and cyclophosphamide, whatever one they're failing, switch to the other one. If they're on IV cyclophosphamide, you can consider oral, which will be a higher exposure. You may consider adding plasmapheresis, particularly if there's diffuse alveolar hemorrhage. You could add IVIG or other immunosuppression. And for other immunosuppression, again, we're really limited mostly to case reports and case series, but avacopan's FDA approved, may have usefulness from that small case series in patients with refractory disease. And obinutuzumab may be justifiable from a rationale standpoint for its effectiveness in rituximab-resistant hematologic disease. Again, we're limited to case reports, but that's what's out there now. So I'll thank you for your attention to our talk, and I'll pass the baton to Dr. Bomback.
Okay, thanks so much, Pietro and Satoru. So Dr. Centriello and I are going to do the second case. This is a 72-year-old man who presents with acute kidney injury. He has a baseline creatinine of 1.2. This case occurred in 2014. So at the time, his baseline creatinine was 1.2 and really only had a history of high blood pressure for 15 years. But in July of 2014, 5 months after that baseline creatinine, he presents to his primary care physician with fatigue, has a creatinine up to 2.8, no fevers, no rash, no arthralgias. Really, fatigue is the main complaint. But with that elevated creatinine, he's referred to a nephrologist. Does not see the nephrologist, unfortunately, until September of 2014. And at that point, the creatinine is up to 4.1. Urine shows proteinuria, hematuria, and the serologies that are sent from that nephrology visit are positive for an ANA, mildly depressed complements, a positive anticardiolipin IgM, but a negative IgG, a positive PR3 ANCA at a level of 47 with under 20 being negative, and a positive MPO ANCA at 76 with again being negative under 20. So this patient was then sent for a kidney biopsy, and I'll hand it off to Dr. Centriello to tell us what's on the biopsy.
All right, thanks, Andy. So, there's a lot of different things this could have been looking at the serologies. There's certainly a concern for immune complex disease with the ANA, low complements, but we have dual ANCA positivity here, so certainly a vasculitic component is on the table, or potentially an overlap of both. And the light microscopic findings here are really more in line of what you see with ANCA vasculitis. So you can see in the PAS stain section here, a necrotizing lesion in the center with GBM rupture and fibrin extravasation. Here's your cellular crescent. This is the H&E of a glomerulus again with fibrinoid necrosis and a large circumferential cellular crescent. Trichrome stain shows the fibrin is bright red. Again, another cellular crescent spilling into the R of the proximal tubule. So a very vasculitic look, but certainly you can see necrosis and crescent formation in the setting of immune complex disease as well. What we typically do is we look at the non-involved gloms and try and get a sense of, do they look like they show other proliferative features? So overlapping ANCA and immune complex GN usually shows overlapping features with mesangial and endocapillary proliferative features. The uninvolved glomeruli in this case are really histologically unremarkable. Mesangial areas look normal, and there's no endocapillary proliferation, which is typical of what you see with ANCA vasculitis in the kidney. This looks like something that's been going on for at least a couple of weeks. There are some fibrocellular crescents as shown here and here on the PAS stain section. And there's even some segmental scars with fibrous burnt out crescents and a few globally sclerotic glomeruli where fibrous crescents are dissecting through the sclerotic tuft. So it's a mixed bag of acute and chronic, kind of a smoldering picture of vasculitis. This is just some more high mag views, just showing you the GBM rupture and fibrin extravasation, typical of fibrinoid necrosis. And once you see a lot of necrosis, ANCA is an important consideration. The tubulointerstitial compartment was fortunately not very scarred. There's a lot of acute tubular injury and edema, accompanied by these red blood cell casts within the tubular lumina. There's the typical lymphoplasmacytic inflammatory infiltrate of ANCA vasculitis in the interstitial compartment. And ANCA is a disease that can involve not only the glomeruli, but arteries as well. And there's no evidence of necrotizing arteritis in this biopsy. Where things get a little challenging is when you get to the immunofluorescence. So ANCA glomerulonephritis is typically pauci-immune, meaning there's little, if any, immune deposits. This particular case did have immune deposits that were too intense for what you typically see for pure ANCA. They were mesangial deposits that stained 2 to 3 plus for IgM. They also stained for kappa and lambda, and there was a little bit of staining for C3 as well. We score our IF from 0 to 3 plus, so anything over 1 plus is really more than what you typically expect to see for pure pauci-immune necrotizing and crescentic GN. That said, as the IF and EM shows you, these deposits are restricted to the mesangium. So they're purely mesangial immune deposits, and they're not accompanied by endocapillary proliferative features. So you really can't blame the necrosis or crescents on the immune complex deposition, but there's certainly more immune deposits than what you see in a run-of-the-mill idiopathic primary ANCA GN. So you can almost imagine this kind of looks like an overlap of a mild mesangial proliferative immune complex GN with an ANCA vasculitis as the primary glomerular disease process. And that indeed was what was diagnosed here, a diffuse necrotizing and crescentic GN in the setting of dual ANCA positivity with low-level, predominantly mesangial immune deposits. I've given you the breakdown here just so you get a sense. About a third of the gloms were uninvolved. Of the involved glomeruli, most of the lesions were active, but there certainly was some degree of chronicity here. And we mentioned the accompanying tubulointerstitial findings here. Andy, you're on mute.
So when you get this case with dual positive ANCAs and far more immunoglobulin staining than you would expect for a pure pauci-immune GN, it really makes you think about a drug-induced vasculitis and specifically hydralazine-induced vasculitis. And in fact, when the patient was when the patient and their treating physician were questioned, that there was use of hydralazine, and in fact the dose had recently been doubled from 100 3 times a day to 200 3 times a day. So this really does point us to this being a hydralazine-induced lesion. Now, in terms of treatment, obviously you're going to stop the hydralazine, but you also can't just rely on stopping the hydralazine when you have such an aggressive lesion as was seen on this lesion. So the patient was given induction therapy with rituximab 1,000 milligrams times 2 doses and put on a prednisone taper. And so if you look at the course of the patient, the creatinine had come to 3.4 when rituximab and steroids were started. Next, please. Oh, sorry. But if you look at the 6-month mark, which is around April of 2015, that would be the time when you would say, well, should I be putting this patient on maintenance therapy? And that's not an obvious answer in the setting of drug-induced vasculitis, because whereas with almost all idiopathic vasculitides and ANCA-associated GNs that are primary, we generally do both induction and maintenance. But if you have a clear drug-induced lesion and you've removed the offending drug and you've given some degree of immunosuppression, usually those patients do not need prolonged maintenance therapy. And there are some patients who don't need any maintenance therapy. So interestingly, in this patient, at the time of the 6-month mark where you would think about redosing the rituximab, that April 2015, the MPO titer is still positive. The PR3 titer is actually negative. So in this assay, less than 19 is negative. So you already essentially cleared one of the ANCAs, and the other one is trending down towards being negative. So in this case, there was no treatment given for maintenance, and it was just induction alone, which is one of the unique wrinkles of treating drug-induced vasculitis, is that you can potentially forego maintenance. Next. I'll let Dr. Santoriello take over from here.
Yeah, and I mean, this, just to show you, this guy had a great outcome going as far out as this, last year, April 2023, his creatinine's as low as it's been since we've had him on our radar. So, we looked at this a while back. This is something we anecdotally feel like we saw with some frequency in our biopsy practice, these kind of overlapping features in the setting of hydralazine. And, there's a lot of small case series out there in the literature. So we decided to put together our experience on this just to kind of get a sense of the flavor of this disease. We were able to identify 80 patients that developed ANCA vasculitis while on hydralazine. I don't know that the mean daily dose is as helpful here, but what's more important is that the vast majority, over 3/4 of these patients, were on hydralazine for at least a year. Most of them, somewhere around 1 to 5 years at the time of their kidney biopsy. So this is not something we expect to see in patients who get started on hydralazine drips in the hospital as a new time exposure. This is something that develops when patients are on this as an outpatient PO med. The mean creatinine you can see here, typical of an ANCA series. I'm going to give you some more of the details on the clinical information here. I don't want to go through all the fine points. I think if you look at this table where we compared hydralazine-associated ANCA-GN and a cohort of matched controls who developed ANCA-GN without exposure to hydralazine, it's occurring in the same demographic, older patients, no real significant racial predilection, no real significant sex predilection. They present clinically in a very similar fashion with RPGN. What was unique, though, were some of the other serologies that were positive in these patients, which could often kind of throw you off the trail in terms of what exactly you're dealing with, and certainly prompts, at least in part, the kidney biopsy. So these patients had a much higher rate of ANA seropositivity. They had a much higher rate of hypocomplementemia, and they were less likely to be pure PR3 ANCA positive. In fact, most of the patients were either MPO ANCA positive or were dual ANCA positive. And in the MPO ANCA positive patients, often tended to be relatively higher titers of MPO ANCA positivity. So when you see the overlapping autoimmune serologies, when you see either mixed or high titer MPO ANCA positivity, these should always be kind of triggers to think about a drug-induced etiology like hydralazine. And the ANA in almost all of these patients correlated with an antihistone antibody. So what's really happening here are these patients are getting a drug, kind of an overlap of a drug-induced lupus and a drug-induced ANCA vasculitis. Their kidney biopsies were, for the most part, very similar compared to run-of-the-mill ANCA-GN in terms of burden of crescentic disease and other typical features that we look for. If you look at these patients, most of them had focal disease where there was at least half the gloms that were uninvolved by necrotizing and crescentic GN. That was a little bit higher than in our overall ANCA group. So there's maybe a potential signal here that this, because you're catching this earlier maybe, or because it's a drug-induced phenomena, there's a little bit more focality. But overall, this has a very similar feel to ANCA-GN. The differences are really with the lupusy component. A lot of these patients, about 30%, had IFs that you would not classify as pauci-immune. The staining was too strong. And these deposits were mostly mesangial, and they were often accompanied by mesangial proliferative features. So you could sort of think of this as about 1/3 of patients have ANCA-GN as their primary processed with kind of a superimposed class 2 lupus-like nephritis, a little mild mesangial proliferation. So again, there's more immune deposits there than your run-of-the-mill idiopathic ANCA, but they're not really enough to explain the necrosis and crescent formation. It's still the ANCA that's driving the glomerular disease and the RPGN in these patients. In terms of follow-up, as you can see here, the induction therapy, this is retrospective. It was a little bit all over the place. Most patients got corticosteroids with either cyclophosphamide or rituximab. Given the date at which the study was done, the rate of plasmapheresis was relatively low. As you can see here, maintenance immunosuppression, only 8 patients. So as to Andy's point, very few of these patients were put on maintenance immunosuppression. That being said, you can see the outcomes here kind of mimic what you expect in a large ANCA series. About 30% of patients went into end-stage kidney disease. There was a mortality rate of around 20%. The combined hard endpoint rate was around 37%. So if you compare this to any large ANCA series, these numbers are about what you would expect. And in this cohort, despite a relatively low incidence of maintenance therapy, the baseline creatinine in the patients who didn't reach one of these hard endpoints was pretty good, 1.5 about milligram per deciliter. So the main points from this series were that when you see these abnormal serologies, particularly dual ANCA positivity or very high titer MPO, with ANAs and other things that are hard to explain. Think about drug-induced vasculitis. The other thing you also want to think about in the right patient group is endocarditis or endovascular bacterial infections. These are two scenarios where the biopsy and clinical presentation can really look like ANCA-GN, but there can be some abnormal serologic findings that you may want to think about other potential contributing factors. As I mentioned, there's an overlap both serologically and to a lesser extent under the microscope of this disease with kind of a mild lupus-like picture. But again, the take-home point is this should be managed as an ANCA vasculitis. It's the ANCA that's driving the disease. The hydralazine is just the second hit. And this cohort shows you that with discontinuation of hydralazine and induction immunosuppression, the outcomes are pretty similar to just primary idiopathic ANCA-GN.
All right, thank you so much, Dr. Centriello. So that actually concludes our program for today. I want to start by thanking everybody at the Columbia CME office for helping put on such a great program. I want to thank Amgen for their support of this program. Hopefully you've had a chance to meet with their vendor in the virtual vending area. And of course, I want to thank all of our amazing faculty, both our external faculty and our internal faculty here from Columbia, to really give such great lectures and such great expert perspective on this disease. And finally, thank you to everybody who is in the audience for participating. Your questions were great. I apologize if we weren't able to get to your questions, but all the more reason to come back next year, where we'll do another program first Friday in March of 2025 to keep this conversation going on ANCA. So thank you, everybody. Have a good rest of your Friday and a good weekend. Thanks.